Maryland Department of Health, but I'm going to turn it first over to Chair Lamb.
All right, thank you, Chair Attar. Glad to have everyone here. Really appreciate the time for the various departments and offices that are here. As was mentioned, we do have a busy agenda, so I think we can just go ahead and hop right in. Anything else, Delegate Attar, members?
No.
All right, so first on the agenda, we have staffing and capacity issues at nursing home in nursing home inspections, and we have the Maryland Department of Health. We have Secretary Herrera Scott here and her team. We'll turn it over to you to kick us off.
Thank you, Senator Lamb. Yes, I'm just going to turn it over to Deputy Secretary Dr. Nilesh Kalyanaraman and our new Executive Director, Tia Witherspoon, who are both on the phone for today's presentation. And Sarah, can you bring up the slides? We have a slide presentation that we're going to run through. Nilesh, are you on? Okay.
Yep, I'm here. Thank you, Secretary. Thank you, Chair Lamb and Chair Attar. As Secretary noted, I'm Deputy Secretary of Public Health and oversee OHCQ. And I did want to take a second to introduce our new Executive Director. She's been there less than 2 months now, Tia Witherspoon, and we will be tag teaming this one. So wanted to give you a brief overview of OHCQ, and then we'll dive into the long-term care staffing issues. So if you can go to the next slide, please, or two forward. So our OHCQ, there we go, thank you. Our OHCQ function is to ensure that we're doing state licensure and or federal certification for 47 different types of providers and programs. And state licensure includes licenses, authorizing applicants to operate and operate a business in the state. And federal certification, which is a little different, recommends certification to CMS to allow a facility to participate in and seek reimbursement from Medicare and Medicaid programs. So we serve both functions. Next slide. And part of that is making sure that we're ensuring that minimum standards for licensure and certification are being met. And one of the key points here is that while we do these surveys to determine if provider is in compliance or not in compliance, we don't have oversight of best practices or the residents or patients' perception of care. Those happen more in the accreditation space and in the quality improvement space. From payers and from others. Ours is to make sure that we're meeting minimum standards. Next slide, please. So we have survey authority. The two big ones that people think about when they think about OHCQ are nursing homes, obviously, which is why we're here. And we conduct those under both state and federal authority, and assisted living programs, which are done under state authority only. You can go forward 2 slides. We've included some background information that will give you the slides, but I don't want to go through org charts and all that kind of stuff for you. But I do want to make sure that you see or have an understanding of the 47 different provider types that we have, ranging from ambulatory care, long-term care is its own thing, assisted living, labs, developmental disabilities, and then the hospital space. So across all of that, we are looking at those minimum standards and certifications. Next slide. So as of the beginning of this fiscal year, we oversee over 22,000 providers in these 47 industries, and this is a 5.5% increase in providers just in the past year. And over the past 5 years, we've seen a 30% increase. And so there's consistent growth in our oversight responsibilities that we're seeing. And for the second year in a row, growth was primarily in the residential services agencies, healthcare staffing agencies, and the developmental disabilities space as well, with clinical labs being the fourth. Next slide. And this is just a graphic representation of that year-on-year growth of the providers that are under our oversight. Next slide. So just a brief overview, our OHCQ administration has budget and accounting, human resources, facility and fleet management, and basic administrative functions, and then our quality improvement piece is critical. So we do have a chief medical officer and chief nursing officer. We have our Maryland Patient Safety Program, which gets root cause analyses of level 1 incidents at hospitals. We have our Healthcare Quality Accounts Grants Program, and then additional IT support to make sure that we're able to parse through all the data we're getting and look at trends. Next slide. From a staffing overview, we have 276 staff, 128 of them are surveyors, and just a little less than half are in our long-term care program. So we've got 59 health facilities surveyors, 3 vacancies on top of that. And then in our other programs, and that references a slide I just showed you a few slides ago, state programs, we have 49 surveyors. Our federal programs, we have an additional 21. And then our laboratories programs is our smallest oversight team of 4 individuals. But focusing in a little bit on the long-term care, it's the $15.5 million budget, and it's about 40% of our total agency OHCQ agency budget. Next slide. So the long-term care unit is responsible for the licensure, certification, and surveying of Maryland's 222 nursing homes. Nursing homes are certified for Medicare and/or Medicaid. And all nursing homes also have to comply with COMAR to be licensed. Next slide. This is just a representation of where the LTC funding sits as part of OHCQ's budget, and you can see the contributions from other portions. So developmental disabilities and assisted living are the next 2 highest portions of our budget. Next item. So the backlog. We are partially federally funded and partially state funded for our LTC survey activities. Federal funds supporting the LTC programs have remained flat since 2014, so over 10 years now, and we generally refer to it as our federal funding cap. And the gap is covered by general funds. This has been an issue across the nation. It's not specific to our state. And along with that CMS recognition that this puts a lot of stress on state survey agencies for them to be able to keep up with the survey activities required. So our backlog started before the pandemic and worsened post-pandemic. We see a severe shortage of nursing applicants, high resignation and retirement rates, particularly during COVID-19. And once again, that was not unique to us. Non-competitive nursing salaries were also part of the challenge that we saw in our staffing. Next slide, please. We also had challenges during the years 2020 to 2022 from state and federal mandates. So CMS halted annual full surveys and redirected surveyors to infection control inspections during COVID, particularly in 2020. We had the MDH network incident, which added another 6-month delay to our survey schedule. We've talked about its impact on OHCQ in the past. No data was lost, but we did operate much more slowly during that time. And there was also a lack of experienced certified nurse surveyors. So one of the keys here is that in order to perform these not just annual surveys, in order to perform the oversight function surveys and complaint inspections, you have to be what's called SMQT certified, and that is granted by CMS. And for at least the past 6 years, we have not hired anybody who has come with their own SMQT certification. So we have had to do that training, and we have actually built out a training center. And we have a fabulous trainer who trains all of the new nurses who come in. But it does take 6 to 12 months to get that certification. And during that time, they are not able to independently or even in any meaningful way add to our throughput while they're being trained up. Next slide. So we have appreciated additional staffing support from the General Assembly. In FY24, OHCQ received 10 new merit positions, and 5 of them went to the long-term care unit. In FY25, OHCQ received 15 new positions, and 12 of those went to the long-term care unit for surveyors, and 1 to the long-term care unit for a coordinator to manage that new team that is being built. Next slide. So the responsibilities under the LTC unit are annual surveys, which per CMS should be conducted no later than 15.9 months after the last one. So 16 months, within 16 months of the previous one. Complaint surveys as well. And then there are revisit surveys that might happen after a visit, either for an annual survey or a complaint, if there is a high level problem that needs to be revisited. Life safety code surveys are required along with annual surveys. We do resident fund surveys and change of ownership surveys as well, which is a state requirement, which we are now doing and have been doing since the start of the year for any change of ownership that occurred this year. Next slide. The long-term care survey process is a two-stage process that the surveyors use to systematically review the requirements and investigate any regulatory challenges or issues that are triggered during that survey. And we have all of our surveyors are connected through their devices at the site. Next slide. So I want to share some of the data that shows what our backlog looks like, and then in the next few slides show you the progress that we've been able to make. So you can see here that now we're at 222 nursing homes. In FY22 and 23, we were at 225. But I think the key part here that we're all concerned about is that the annual full surveys were done, were 28, 42, and 47 in those past 3 fiscal years, which is far short of the 222, recognizing that even with the 16-month period, we were still not at the mark. The other part that I want to point you towards is also the complaints and facility reported incidents. And the distinction between that is complaints come in from somebody outside of the facility leadership, and then nursing homes can also, as an entity, report any incidents that they discover, which are called facility report incidents. We combine all of that into one bucket. And as you can see, we've had over 4,000 of those, but the number that we're clearing, complaints and FRI investigations has been short of that. So we have been falling behind on that. Next slide, please. What I'm happy to report is that we are starting to catch up. And I'm going to go through it in a minute about how that's happening. But I do want to point out that we have seen, even from FY22 to 24, we've seen an increase in 48% increase in completed nursing home inspections. But much more importantly, in the first 5 months of this fiscal year, we've seen that our rate of annual full survey completion increased by about 160%. In fact, in 5 months so far, we have done more annual surveys this fiscal year than in fiscal year 24, and we're on pace to continue and accelerate that growth. So we are on the right direction for our annual survey clearance rate. Next slide, please. And that same is true for our intakes, which, as I mentioned, is our complaints plus facility reported incidents. From FY22 to 24, we saw a 45% increase in completed investigations. But like I said, more importantly, for the first 5 months of this fiscal year, we've seen a 72% increase just from FY24 in our clearance rate of this. And in fact, about a year and a half ago, we were at 9,500 outstanding intakes. We are now down to 5,900, and that number steadily is coming down. Next slide. Part of the challenge that we've had is an increase in the number of intakes. As you can see here, in FY18, there was about 3,600. It peaked in FY23 at 4,600, which is a large increase in those complaints, and for the first time came down in FY24 to 4,000. We're hoping to see where that equilibrium is, and that it is somewhere around that 3,600 to 4,000 mark. But it is something we are keeping our eye on in terms of the needs for staffing that we may have in the future. Next slide. So one thing to note is that Maryland follows the CMS triage protocol. That is a requirement, and we are required to triage any of the complaints, the intakes that come in, and for those that are the highest, they get escalated to senior staff for review and completion. So that's the immediate jeopardy ones. And in fact, we do not have any immediate jeopardies outstanding. We're always up to date on that. Next slide. So just to break that down a little further, we have the 4 tiers are immediate jeopardy, a high, a medium, and a low triage categorization. And we are, like I said, we are up to date on our immediate jeopardy, and in our high, we are not fully up to date, but we are close to that and working to clear that backlog first. Next slide. So there are a number of items that we have put into place already to address this backlog, and one of those has been to accelerate our hiring and of long-term care nurse surveyors, and to get more positions. And for that, we appreciate like I said, the General Assembly's funding of new positions. And so we have currently 59 of those nurse surveyors, with 16 in training. And so as those 16 in training continue through and become certified, once they become certified, that will then increase our throughput. But while they are in training, they don't really add to our throughput yet. So it is an investment that will be paying off over the coming months. Next slide. We've also gone through PIN conversions, and all of those PIN conversions, all of those positions, have been converted and filled. And then I mentioned salaries as an issue, and the state salary increase for nurses by 2 grades has tremendously helped our recruitment as well. And so the combination of the additional positions and the increased salary funding has helped us with our recruitment, and then the training center that I mentioned has helped us with our retention. Next slide. This just speaks a little bit more to the training. And since July 23, we've hired 30 new LTC surveyors, and all of them have required training. So that's about half of our staff. And so that turnover has also impacted us as well. One key thing I want to talk to you about here is improving our efficiencies, and Secretary Scott has been a real key driver of this, is looking at our processes and ensuring that we are going through things like simple things like Wi-Fi access, location from where people live to where they're doing their surveys, throughput in terms of completing the reports from inspections. We've seen somewhere from about a 15 to 20% increase in our efficiency from putting these changes into place over the past, I want to say, about 6 months or so. Next slide. Another piece of our effort is around subcontracting. So the General Assembly did provide funding for OHCQ to get subcontractors to clear out the backlog, and we have contracted with two different staffing agencies to be able to do that. Right now, we have 9 surveyors working 7 days a week. Most of them are during the week. Some of them are on the weekend. And as more surveyors become available through those staffing agencies, we have the capacity to take more surveyors on, and that's going to help us clear through the backlog. The other piece is that CMS has been, for certain states that are the furthest behind, has provided some teams on contract to do surveying as well, and they've completed 13 annual surveys for us. Over the past 6 months or so. That support is uncertain. We were told initially that there would be 7, and that would be it. We've gotten more from them, so we're not counting on that, but we're certainly happy as long as that support is available from the federal government. Next slide. So I just wanted to provide, where are we going this? Our estimate is that it's going to take about 2 to 3 years to catch up. But as you can see, our trajectory is already in the first, I would say, about 6 months of this effort, yielding some significant results. And I would say the big issue here is that the long lead time for nurse surveyors to get certified is the reason. So even though we have hired them, it still takes a while for their efforts to register into our clearance rates. But like I said, as they become certified, we will see an acceleration in our clearance rate. That is where I wanted to end here, that I think that we are in a good position to continue the successes that we've put into place, the changes in staffing, training, contractors, process efficiencies, and of course our new executive director who has stepped right in and led the charge on this. So I wanted to stop there and happy to take any questions.
Are there any questions from any of the members? Thank you, Deputy Secretary.
I have a question thank you for the presentation.
Perfect.
Appreciate the update here. I think that's helpful to be able to see some of these numbers. I guess it sounds as though the backlog is still being fully reviewed, right? So every complaint that's come in, every pending review that needs to be done, they still will be done, right? So complaints that may have piled up and been backlogged from, for example, residents, those will be followed up upon at some point, right?
So they do get followed up. So the way it works is that for the highs, those will get done at the time of the annual survey. CMS has put out guidance to all states that for any low or medium complaints that are over a year old, they should be reviewed. And if they're of low concern or outdated, they can be administratively closed. If they're still an ongoing concern, we will investigate them at the time of the annual survey. So they're all being assessed.
But what do you have a sense of the magnitude of the low and medium complaints that maybe just administratively waived?
Yeah, it's probably for the oldest surveys, it's probably somewhere in the 40 to 50% range or in that category.
And the oldest surveys going back, how many years now are we talking about?
At this point, what year are we in? 2024. We're at about 4 years out. And so there are some surveys from, there are some facilities that haven't had an annual survey since 2020.
There are some facilities that have not had an annual survey since 2020.
Mm-hmm. Correct.
Are those facilities being prioritized for review, or?
Yes, absolutely. Yes, absolutely.
That
So
seems like a long time to go without a survey.
You're correct. You're correct, Senator Lamb. That's the problem we're trying to. That's the problem we're trying to move through fast. I would say that our prioritization is we are going to the oldest to do our annual surveys. As I mentioned, for immediate jeopardy ones, we are going out right away. For our highs, we're triaging them and going out. I believe it's within 18 days, but I can defer to Tia for that. So it doesn't mean that we've never been to a facility in that time frame, but it does mean we haven't done a comprehensive annual survey. And that's why I said that just being able to do 51 surveys in the first 5 months, right, puts us on track to bring down that time tremendously. And while we do project 2 to 3 years, we're about 6 months into that already.
Okay. Is there anything that extends beyond 4 years? Because I'm looking at a Washington Post article from earlier this year that said, according to CMS data, the state has failed to inspect 104 nursing facilities for more than 4 years.
So 2 things to that. One is that because our velocity has been increasing, you're right. That's what was written a number of months ago, but we are catching up, right? We are doing those 2019s and we are, I believe, into 2020. The second piece of that is that CMS data lags our data just from a very process-oriented standpoint. We do our survey. We then have to submit that to CMS. CMS reviews it. They may have either questions, ask us to go out. It may take time for them to clear it on their side. And so that might add anywhere from a few months to a half a year. But I think from our operational standpoint, we're really focused on, have we been there to do the annual survey? Because that kind of resets the clock. So you will see a data lag from CMS. So even as I tell you that we've done 51, CMS does not register that we've done 51 in 5 months, right? Until they clear those from their database, from their process into their database. So I do want to acknowledge that kind of data piece because that will come up, I am sure.
Right. Yeah, no, I get the data lag. The reporting to the feds takes time and whatnot for them to clear through. But you believe that as of now, there's no annual surveys that extend more than 4 years that are outstanding.
Yes, and I will double check on that. But we have been working assiduously to get out of that 29, get those that were done 2019 to have us be out there. Yes.
Okay. I know because my colleague on the Senate Finance Committee, Senator Kramer, has asked this question previously earlier this year, where he represents Montgomery County, and there was an agreement that tentatively had been sketched out with Montgomery County to allow the county to have 10 inspectors that are supported, I think, at the county level to help with the surveys at nursing facilities. And that, for some reason, didn't go through. I know Senator Kramer has been concerned with the backlog of these reviews in Montgomery County. He's heard from a lot of constituents. So can you explain why that agreement was canceled with Montgomery County that seemingly would have allowed, or at least some of their counties' reviews and surveys to be done more expeditiously?
So the history of this is that there were agreements with a number of counties throughout the state, where OHCQ was providing some amount of funds, counties were providing some amount of funds, and this was a number of years ago. And what OHCQ noted was that it was costing more and more inefficient to be able to do those surveys because we were diverting funds, and then it was variable as to what was happening at that county level. As a state survey agency, as the designated state survey agency, we're responsible. We can't abrogate our responsibility because we contracted with the county. That said, since that's happened, and certainly Senator Kramer we've talked with Senator Kramer about this. We are open to and happy to support county investments in survey activity, and I've been having conversations with Montgomery County. I think the most recent one was just a couple of weeks ago now, where they're looking at a pathway to get funding. And I think that's probably the biggest issue is just working through the funding and how we make sure that, how we make sure that the county is able to put the funding in to be able to expand that nursing surveyor capacity. But we are open to that.
What are these other alternative methods that you're mentioning that the county could use to help support some of this backlog? You mean funding for additional MDH inspectors, or I guess, can you?
Well, that's what we would have to work out. So, I think so the funding would have to be for additional surveyors. There's really not a lot of, this is a brute muscle kind of problem, right? We just need more people to do the work. And so it's really county funding to add surveyors. We'd have to work through the details of what the oversight is, who's employing them and all that. And that's we'll have to negotiate that. But at the core of it is, if they're able to invest in it, we can figure out how to make that happen.
How is that different than the agreement that was canceled with Montgomery County earlier, where it seems like they were willing to support some funding for additional county inspectors? Is the difference here that you're describing that they would still be state inspectors?
The difference is that in the prior iteration, OHCQ was giving money to counties.
Okay.
And then in this iteration, OHCQ is not in a position to give money to counties, but we're happy to support and integrate additionally funded staff by counties.
Oh, okay. So this is if the county is willing to support additional funding, that might allow the state to bring on board more surveyors.
Correct. To work in that county, and we can work out the details, but OHCQ isn't going to give a piece of its funding over to a county because we're still responsible for the activities. We can't abrogate our responsibilities.
Okay. And then on one of the slides, I think slide 21, you were talking about intakes. And those numbers went through rather quickly. I'm looking at it again, but is it your sense that we're seeing a higher volume of intakes than we were before? Has the number of intakes increased? The number of intakes has increased, I guess. Over the last couple
it has, and at its peak, it was about 30% higher. So in FY23, it was about 4,600, compared to just through 4 or 5 years ago, where it was about 3,600. So that's just a large volume increase.
So when you're saying you're trending in the right direction, you're trying to catch up on the backlog here, but at the same time, the hole is getting deeper, right, at a faster rate.
Well, yes. I mean, we're certainly cognizant, right, that even as we're clearing the backlog, more is coming into the pipeline, and that's why we've said that it's going to take the 2 to 3 years. But that's part of our catch up, and that's, you know, when we get those nurse surveyors in training certified, that'll help us catch up.
Why?
And Senator Lamb, I just want to qualify, all intakes are not created equally, so that would be better representation to qualify the intakes moving forward for you, and we can get that. So some of the intakes are low acuity, and it could be that the floors were dirty, or I didn't like the way the staff spoke to me, to more egregious things such as could be, you know, considered IJ. So we need to break those out. But oftentimes they are low acuity that can be resolved at first pass as soon as you come into the facility. So we'll need to break those out for you.
Got it. Yeah, certainly understand not everything is IJ and not everything's, you know, non-IJ high priority either. So there certainly a spectrum of different kind of intakes. I guess the last follow-up question here then is, do you have a sense why these intakes are increasing in number for the last couple of years? Why is the trend of intakes going up?
Well, it's a trend we've seen in other states as well. I don't know that I have a very satisfying answer. I think COVID was certainly sort of part of it. I do think that not being there as frequently does lead to some additional complaints. And so we're hoping to see that as we go and clear them out, that will hopefully decrease the aggregate number that we're seeing coming in each year. But, you know, like I said, FY24 was the first time that we saw a significant downturn in that volume. So very glad to see that, frankly.
Okay. All right. Thank you. Looks like Senator Benson has a question. Senator, I think you're muted. There we go.
Yes, good morning. I must tell you all that this whole issue of nursing homes and assisted living have been very constant for us here in Prince George's County. I mean, almost on a weekly basis, we receive complaints regarding conditions at nursing homes. I would want to ask this question. The backlog of inspections. I spoke this week to the health department and to a couple, to DPI, and I'm trying to think of the other agency. We're trying to figure out why it is that there has been an absence of inspection in most of our nursing homes and the assisted living facilities. The nursing homes are really where the problem is as we see it. I mean, in these nursing homes, it is not just the behavior of the of the supervisory staff, but in one, and you all are familiar, at one, there was an absence of an administrator who oversaw the nursing home for at least 4 or 5 months. That's very unacceptable. And in the course of all of that, the people who were there, the little patients, 83 of the little people, went through all kinds of ordeals. They did not have access to their doctors. Many of them were so ill, some of them passed away. The food is a problem. I mean, the story goes on and on. You already know it. I'm just trying to figure out, what must we do? When we talk with these different agencies in Prince George's County, they are saying that their ability to do anything against these nursing homes is very limited. They have very limited authority. So I am inclined to agree with Senator Kramer. We have people in Prince George's County or agencies that are willing to work with the state so that we can have more inspection, more people on board to do the inspections. The question becomes, when they find these outrageous behaviors and some of the things that are going on in our nursing home, and it's reported to you all, the problem remains, what do we do to say to the owners of these nursing homes, this is very unacceptable, and this is what we're going to do? What we're all hearing is, and what I was told this week, is that you all are very, very unwilling to close down many of the nursing homes. You're asking them to improve. I'm just trying to figure out what we need to do to bring some peace and quiet to the patients who are in these nursing homes. It's very, I'm telling you, if you visit, it's very, very terrible. How do we hold these
Thank you,
owners
Senator.
accountable? How do we say to them, listen, you can't keep on nickel and diming this nursing home here. You got to pay your staff. What is their obligation? And what happens to them when they refuse to do what you all ask them to do?
I understand, Senator Benson. I have been to nursing homes. I understand what you're saying. I'm actually gonna ask Tia to talk a little bit about what our process is when we find problems in a nursing home, so that we can hold the owners accountable.
Thank you, Dr. K. Senator, definitely understand your concerns here, and certainly sympathize with the residents. One of the things that to terminate, to get straight to the point, to terminate a nursing home, what we have to do to terminate a license is the level of the incident has to be very egregious, and it has to rise to immediate jeopardy by CMS's definition. And unfortunately, most of the deficiencies that we see are not meeting the CMS threshold for immediate jeopardy. If we do see immediate jeopardy and it's not resolved, we can, in accordance with CMS guidance and regulations, we can shut down nursing homes within 3 business days. Otherwise, what we have to do, Senator, and I know that this can be frustrating, is we do have to work with the facility to put in plans of corrections and improvement plans in place. And we do go out, we do revisits, we check with them. We can deny that improvement plan if we feel that it's not sufficient or not adequate enough. So we do have to work with the facilities, and we do, when we go in, we are talking to residents and family and staff about this as well.
You know, when you talk about the residents, a lot of the residents say to me, Senator Benson, I'm afraid to complain, because if I complain too much, they've told me that they're going to put me out of here. And that's, you know, when you talk to these little frail senior citizens who are sick and feel that there's no place else that they can go, they are not going to be inclined to really tell people what the problem is. But now I tell you, they told me that, Senator Benson, this is what's happening here. And the behavior of the supervisory staff and the nursing staff, I have to tell you, I mean, I can't even describe it. It's just it's so unfair for these little people. It really is.
Senator Benson, I'd say that I wanted to add one thing to what Tia said, which is that we can also levy monetary penalties. That is another option, and we do use that. But more to the point, you know, when you do hear anything, I would ask you to please reach out to myself or Tia, or have your staff do that, and we will address that. I do hear that, you know, patients are sometimes hesitant to do it, and it takes somebody else to share that with us. And so please know that we're available for that.
Okay.
Thank you, Senator Benson. Delegate Harrison.
Thank you.
Okay, thank you. I'm just having all kinds of technical issues this morning, so I apologize, one, for being late. But I wanted to ask, Senator Benson and I share the same district. We're in the same district. And a few weeks ago, we had been called to one of our nursing homes because of, you know, the concern of ongoing problems. And so there are a couple of things that I wanted to bring up and then just ask your get your feedback. So I got in on the part of the presentation where you were talking about how often you are inspecting these facilities, and I know that that there's a lag time. Um, so 4 years, Senator Lamb went down the path of the amount of time in 4 years. But when you do an inspection and you find deficiencies, first of all, how quickly do you go back to check to make sure that that those deficiencies have been corrected? Are you waiting another year? I know that you give them an opportunity to put a plan in place. Are you waiting until that plan is fully in place and has been underway for a while? Are you doing random pop-up inspections? Can you just kind of walk through that with me? And I'll reiterate a little bit more on some of the things that Senator Benson mentioned.
So yeah, I'll turn this one over to you.
Thanks. Yes, thank you. Thank you, Delegate, for that question. So when we get something like that and a plan of correction is submitted to OHCQ, we review that plan of correction with the facility. We can also do revisits. So if we feel like the plan of correction is not sufficient and it's not within a whole year or the next annual visit, we keep that survey cycle open so we can go back and revisit them at any time if we feel like there's an issue. Also, if we get a complaint in, another complaint in that we want to go back and reinvestigate, we're hearing different things, we can go back in and revisit a facility too within that window of 15 and 9 months. We're also, if we find uncover something and we give them time to fix it, we can go back in and make sure that it's been addressed. So we do not have to wait the entire time, close out the survey, wait the time, go back another 15 to 9 months. We can do that within the time that we're there. So I hope that answers your question. So we're definitely not making folks wait a whole nother cycle, 15 months or 16 months for us to come back in and revisit them. And at any time, if we get a complaint that we feel rises to the level of immediate jeopardy, we're out there within 3 days to visit them.
Is it your department or agency that inspects elevators or responds to those particular issues?
You do have life safety, what we call life safety code, and those are kind of your facility management. They're looking at elevators, HVAC systems, things like that. So we do have life safety code surveyors who go out and do inspections as well as a part of the process. Yes, ma'am.
In that life safety, then when you say HVAC, you're ensuring that they're looking at the HVAC and ensuring that there isn't moisture that's built up so that there's mold. Legionnaire's disease is the first thing that came to my mind, those types of things. Are they looking at those issues or those potential issues?
They are. So they have we have a suggested set of things that we have to look at from CMS. But if it leads to we're seeing those type of issues or we're hearing those types of things, we will look into those things. We're making sure that the temperature in the building when it's cold is 71 degrees. So we are looking into, we will look into all of those things when we go out there on the life safety code survey.
And then on the ombudsman, does that fall under you? The ombudsman program?
No, it doesn't. It doesn't fall under Office of Healthcare Quality.
Okay. Well, I'll tell you, we had a very, very disturbing visit with one of our facilities. And facility, when you drive up, you think it's the best place in the world because it's beautiful. The grounds are wonderful. They're well kept. But as soon as you go in, you're not necessarily greeted very warmly. And then the smell gets you right as soon as you walk in, and you go up on another floor and it's unbearable. And you have individuals who are in there who just are not mobile. And they are in fact afraid to speak up. So much so that, we were in there, the manager, executive director, whatever the title is, who's new, had come in to hopefully correct some issues, but would not even allow those individuals, did not want them to meet with us without what he said was it was a requirement of the ombudsman to be there, which, we later found out is not accurate. So I guess there's some level of training that needs to occur there. But they're so afraid to speak up in front of them that they wouldn't even share. We couldn't even get them to speak really with us. We had to pull out of them, some of the concerns. And then the one gentleman who's not mobile at all, but, hand wrote his concerns. So I'm not sure whether I don't know how they're making their complaints, whether they're going through the ombudsman when the ombudsman does show up, whether they're actually calling or having a family member call. People can't get to their appointments because for whatever reason, they're placed into this facility that's not even in their county, but all of their doctors are in another county and they can't get there. I don't know. It's just, it's so disheartening. And you see some of the people, they just, it's terrible. It's terrible. And an inspection once a year, I guess, is okay. But honestly, they need it more often, and they need to be pop-up visits to make sure, because these are the most vulnerable people that are out here. They are reliant on those people who are supposedly, changing them and changing their bedding and feeding them and giving them treatment. It's sad. It's the worst thing ever. And I'm a little bit more sensitive. My mother was a geriatric nurse, and she had a problem we had a problem with the facility when she had to go in. It's the most disheartening thing ever. These people are incredibly vulnerable. They don't deserve to have that type of treatment and to be in a facility that's unclean, and they're afraid to speak up. I just can't imagine what that must feel like for them. Thank you. I guess I'm off my box now.
Well,
I wanted to, let me just jump in also. On yesterday, we got a phone call that there was no heat in the building. No heat.
Mm.
How about that? She's absolutely right. And yes, we are very passionate about our little senior citizens and those who can't speak for themselves. That facility is shameful. And the way that they talk to the people and the way that we were greeted at the front door by the supervisor, who had her arms folded and walked away as we tried to question her. Listen, nursing homes are a problem because of the way that they treat those people who come there. I don't know what you all can do, but the owners of this complex are up in New York. So they have no sensitivity to the people who are there. It is unacceptable. And they're getting a boatload of money on the backs of those dear little souls, and they treat them with such disrespect. The facility itself, that's these little people's home. They complain about the fact that they couldn't get their diapers changed. Some of the people weren't fed. It is a very terrible situation. And it's not just there. We have several other facilities that are in the same situation.
Senator Benson, I do want to say change of ownership is something that we are actively looking at, and Dr. Kalyana and Tia Witherspoon are working on a strategy that we will be implementing in 2025. we need to tighten up the state's process and how we look at change of ownership and that what that does to staffing levels. We know that MHCC has done some work on this, but there's lots of room for improvement there. So we will be taking that on already in 2025 for sure. So yes, you are correct on what ownership is doing, especially out-of-state ownership, and we recognize that. So it's not just about the inspections, but then what happens when that change of ownership happens in the state, especially with out-of-state of ownership, what it does to the facility.
Thank you very much.
And Senator Benson, I just want to reiterate, whenever you hear a complaint, please let us know. You know, things like heat, very important. I can tell you in the last week, we've been out of a facility where there was no heat, working with the nursing home to make sure that residents are taken care of. So please share them, because if we don't know about it, we have no ability to act on it.
Thank you.
And I just want to say thank you, Senator Benson and Delegate Harrison, because your concerns, I believe we all share, and they're extremely important. And if there are no further questions regarding the nursing homes, Chair Lamb, do you have any follow-up? If not, we can move on to Clifton Perkins.
No, let's keep going. Thank
Okay.
you.
Secretary, are you going to be speaking?
Yes, Sarah, can you bring up the next deck? Sarah? Okay, great, thank you. Next slide. So on the phone with me is Erin McMullen, Chief of Staff, and we've been working this issue very closely together. Here's a short agenda. I wanted to give an overview on Clifton T. Perkins Hospital Center, who they serve, the recent Washington Post inquiry, immediate actions, the third-party evaluator, and HR activities. Next slide. Next slide. So just as a reminder, it's a forensic inpatient psychiatric hospital that offers both maximum security and medium security level inpatient behavioral health. And just to distinguish forensics, so these are patients that have been charged with a crime. So like any facility where people have been charged with a crime, there is like a Sally port where you go in, you know, one gate locks, you go in, and then the other gate opens, you go in. So it is a hospital, but it is a maximum security forensic hospital. And these are patients with very serious charges, are the only ones that can be admitted to Clifton T. Perkins Hospital. Bed capacity is 289 beds, and it provides treatment to individuals who've been found incompetent to stand trial or have been adjudicated as not criminally responsible for a violent felony. Next slide. In recent history, I think you all remember in 2011, unfortunately, there were 2 patient homicides that occurred at Clifton T. Perkins. And at that time, there was an external evaluator who addressed concerns in the security and safety of the facility. And as a result of that evaluation, there were significant resources that were deployed to the hospital, including nearly 100 new positions between 2012 and 2013. The previous administration failed to maintain investments or follow through on the changes that were initiated as a result of the evaluation. Oversight of Perkins, as well as the state psychiatric hospitals, were centralized under a healthcare system, removing clinical oversight. So the rationale was by creating a healthcare system that there would be efficiencies gained, and that might be true for things like ordering supplies and procurement, but by making a system of care, the clinical oversight at the MDH level and at was lost, and so that was had something that was a direct result of making this system of care. Next slide. So this is a background on the staffing changes. So there was 100 net new positions that were added over time. And then especially from 21 to 22, there was, and 22 to 23, there was a erosion of at least 50 of those positions. And you can see how the positions increase after the result of that homicide, and then the decline, especially from 2019 to early 23 when we took office. And then the more recent decline has just been as a result of more recent turnover. Next slide. So I wanted to give background on recent findings, and you have the sources. So we went back in history and looked at different JCRs and DLS just to understand what happened during the prior administration. So there was a JCR from 2018 that talked about direct care recruitment and retention study that had findings that said across state hospitals, recruitment and retention of direct care position showed a vacancy rate that had almost doubled, rising from 7.25% in December 2014 to 14% in June 2018. And then in 2018, DLS staffing did a study that's about the adequacy of staffing. And they noted that both documented evidence as well as anecdotal evidence to suggest that BHA is understaffed, not only in the direct care workers, but security personnel, and that training and compensation for both direct care workers and security personnel was needed to reduce staff turnover. They also noted in their report that back to the change in the patients that we've seen, that patients have changed from 38% forensic to over 90% forensic. And even in the 2 years that I've been in this role, I will say that the acuity of the patients has changed. They are much sicker than what they used to be, and the criminality or the seriousness of the charges has gone up significantly. Next slide. In 2020, another DLS from the operating budget establishes a goal of staff time lost due to injuries sustained in the performance of their job duties for the facilities, and noted that Clifton T. Perkins Hospital exceeded the standard every year from 2015 to 2019. And then again, in a DLS operating budget analysis for 22 and again in 23, talked about overtime expenditures, again, largely concentrated in Clifton T. Perkins, and that overtime increases by 1.2 million in fiscal year 2022. Almost exclusively due to Perkins, and that Perkins accounted for 8.3 million of the total 17.1 million in overtime expenses. It noted that the losses of 22.8 regular employee positions in the budget was largely driven by the hospitals, particularly Perkins. So increasing overtime, loss in full-time positions, increase in injury during the same time because of the decrease in staffing ratios at the facilities. Next slide. Talk a little bit about the Washington Post inquiry earlier this year and the immediate actions. Next slide. So in February 2024, the Washington Post reports that Dr. Moran is on leave and 2 employees have taken out a peace order. In May 2024, the Washington Post inquiry outlined critical incidents at the facility. And then in October 2024, Washington Post investigation highlights staff complaints, facility violence, and critical incidents. Next slide. Immediate actions. Dr. Moran is no longer employed at MDH. Office of Healthcare Quality survey initiated in June 2024, resulting in the development of a corrective action plan, and that the MDH healthcare system starts reporting directly to the secretary. So it's no longer a system of care, but actually reports to me. So all the hospitals now report to the healthcare secretary. Next slide. New incidents, we had a policy change in how incidents are reporting. So they used to roll up through the facilities, through a facility director, through the deputy secretary of operations. They were all treated equally. So it could be everything from the heat was out to serious injury. And so now we rolled out a new incident, a triaging of incidents, and then a tracking with real-time notifications to leadership. That includes priority levels, and these are the categories. So priority 1 is situations involving death, serious injury, or bodily harm to a person, elopement of any individual that is court involved. Priority 2, situations involving a major or long-term facility or program disruption, so sustained loss of infrastructure inclusive of space, heat, air conditioning, water, loss of state vehicles, loss of technology, resulting in program downtime, elopement of voluntary patients, and then priority 3, situations involving a temporary minor disruption or quick resolution, such as a tree fell blocking an entrance, for example. We are triaging this triage system because it's not perfect, and we may need to add a 4th layer, but this continues to evolve as the facilities get used to reporting in this way. Next slide. Third-party evaluation. So similar to what happened in 2011, we also brought in a third-party evaluator to help us and guide us on not only to look at the evaluation that was done in 2011, were the policies still relevant, how have we deviated from those prior recommendations, but also to inform us on the state of the state today. So we initiated a grant to a third-party evaluator working with the National Association of State Mental Health Program Directors, and we asked them to look at the list there: the administration of the facility, security, employee morale and culture, patient morale and culture, patient grievances, and stakeholder involvement. We also asked them to work not only look at speak to people, but look at the work conducted via medical review committee. Next slide. And the activities included reviewing summary materials pertaining to adverse events. They worked with OHCQ, looking at their findings. They looked at laws and regulations and any relevant policies and procedures that the facilities had. The evaluators conducted on-site visits on October 8th and 9th with a follow-up visit on November 4th and 5th. The on-site visits, including meeting with individuals, including patient, staff, and right advisors, the meetings with interested stakeholders, including Disability Rights Maryland and unions representing employees at Perkins. And for AFSCME and AFT, we did give them a heads up of the dates that the evaluators would be on site so they could work directly with the unions to have people available and space available so they could speak with the evaluators without any intervention from us or anyone at the facility, so they could be as candid as they needed to be with the evaluators. Next slide. A final report with key findings and recommendations will be delivered to the department on January 1st, and we do have preliminary findings that have been shared with us that were shared a few weeks ago, and we're actively evaluating those findings and implementing some of the recommendations that were made. We are absolutely committed to sharing the key findings while protecting patient medical information. Next slide. From an HR perspective, we've done a lot of work. We have acting leadership in place. At the time we put these slides together, hiring was underway, but I can tell you today we had our CEO commit to the role. So as of today, we have hired a new CEO who's a respective, known physician leader in the state of Maryland. We have a new CFO who will start January 8th. The CEO will start February 18th. They had to give notice. We are actively looking for a COO. So we've changed the whole leadership structure of Perkins. And then working with our new HR director who put together a whole HR strategy for Perkins in particular. Next slide. She's formed an HR committee that's tasked with addressing vacancies at Perkins. She's focused on streamlining recruitment and outreach strategies. She's prioritized job postings with all vacancy classification series with active job announcements. We're using social media to highlight Perkins and employment opportunities. We're also interviewing assistants with second round interviews, including job shadowing for top candidates to fill clinical vacancies. We thought the job shadowing was incredibly important. We've had a lot of people apply from hospitals at Perkins, but then leave after a short time because they don't understand the distinction between a forensic facility and working in a hospital. And so we want to make sure that people understand the difference. But we're also putting mentors in place, so they have persons that they can work with and can feel supported in the facilities as they join the Perkins teams. Next slide. We've also had multiple job fairs. We had an on-site career fair held at Clifton T. Perkins on November 19th. The event focused on clinical positions and included on-site interviews. The staff successfully interviewed 68 security attendant positions, nursing candidates, 18 licensed practical nurse candidates, and 17 registered nurse candidates. As of December 5th, we have confirmed a total of 17 new hires, 12 are scheduled for December 11th, 7 clinical appointments, and 5 for January 8th, all clinical. There are an additional 13 appointments pending as they are currently undergoing various stages of reference and background checks before offers can be extended. So a lot of work is happening to fill the vacancies we have. We are also actively looking at all our vacant pins to backfill the 50 pins that were lost during the prior administrations to bring us back to staffing based on the recommendations of the evaluation in 2011. And with that, I'll take any questions. I went through that quickly, but just wanted to give an update of all the work that's been happening. Senator Lamb, I'll turn it over to you.
Sure, thank you. So appreciate the background here on this. Obviously there's been a lot going on at Perkins. You outlined some of that, but it sounds as though, a lot of these concerns have been longstanding, and there's a lot of history here. But I guess, within the last 2 years or so, based on the reporting from the Washington Post, there have been a patient death, a rape of a patient, and a riot. And I'm just trying to understand, how it could have gotten to this point. Because, a lot of the things that you outlined earlier in the preceding few minutes, which is great, is all prospective. A lot of that is prospective. And, as we were discussing yesterday in a different hearing, there's a prospective work, but there's also an understanding of how we got here and how it could have gotten to this point. It's pretty serious to have, a patient death, a rape, and a riot occur at one of our state hospital facilities. Can you at least give us a sense of how it could have gotten to this point as a starting point for this discussion?
So I agree with everything you just said, and just want to talk about the layers before the way, because of the system and the way before things got to me, if they got to me at all. So we had the CEO, then we had the facilities director, then the deputy secretary before it got to me. And for one of the in each of the cases, they were not presented the way they were presented in the Washington Post. And only in hindsight do I understand the cases the way the Washington Post presented the cases, but they were not presented. The clinical case, the death, was presented as a complication of another condition, a chronic condition that the person had. So that's the way that was presented to me. And there was documentation of the chronic condition, but so that was the way that case was presented. The the riot was never presented as a riot. It was presented as an altercation between two individuals that was taken care of on the floor, and then the individuals were separated. So unfortunately, the news that was the way it was presented to me was not ultimately what happened in the facility. And even after one of the events, when I did go to the facility, then what I got was the tour that was set up for me and what they wanted me to see. And even when I asked to speak to employees, the employees were picked for me to speak to. I didn't get to just speak to anyone. The employees were picked on who I would speak to. So everything was very controlled on what I got to see, unfortunately.
So, you know, and I get that. I think, I guess what you just contended over the last minute was that the information that was relayed to you by your staff was not framed in the way to accurately reflect the seriousness of what actually took place in the facility itself.
Correct.
And, you know, I guess so is your contention that you were misled by your staff?
Yes.
And how was that allowed to happen? I mean, I guess, you know, when you hear of a patient death in one of our state's facilities, these are folks that, you know, are actually under the care of the state. They can't go anywhere. They're under our care and they're restricted to our facility. You know, it's our responsibility. Their health and well-being is obviously our responsibility. And if there's a death, does that not trigger you to peer under the hood a little bit more to understand what might have happened here that led to an individual dying in our care?
So, like any clinical scenario, it depends on the patient. It depends on the age of the patient. It depends on the chronic conditions the patient had. So if it's a 35-year-old with no comorbidities other than a behavioral health diagnosis, yes. If it's a 69-year-old with congestive heart failure, stage 3, and other complex chronic conditions in addition to the behavioral health, no, I may not peer under the hood more than what gets presented to me. So in the scenario, the person had a complex medical condition that was closer to end stage than not end stage. And the way we do have somatic physicians in the facility, and the somatic physician explained it to me as a complication of their chronic condition.
And so you took all this at face value of what your staff was conveying to you, and you feel like that was misleading to you.
Well, in hindsight,
you weren't painted the full picture of what happened.
At the time, what was presented to me seemed reasonable. So I didn't take any action based on what was presented to me. Only in hindsight, did I look under the hood based on what was shared with me, quite frankly, from the Washington Post reporter. Did I start looking and then start to see the holes in the story and then understand what happened?
Did you not get a sense of a drumbeat of concerns that have come? Because it wasn't just this patient death. It seems like there were staffing issues, there were safety concerns, there were assaults that took place, there was the rape, there was the riot. At what point does this drumbeat of incidents that harm patients and have been brought to your attention by other staff as well rise to a level that you actually look at this a little bit more and pay a little more attention to what had taken place here?
I run a very large agency. We have lots of people that are supposed to be reviewing the materials. I had a deputy secretary, I had a facilities director, and a CEO that were supposed to be doing their jobs and advising appropriately. And unfortunately, I had leaders in place that were not only advising me well, but were misrepresenting the facts of what was happening in the facilities. And all those people are now gone.
you point out that these folks, did not do you any service in how they were conveying this information to you. The Post article did point out that Dr. Moran was promoted in February of 2023, and that was a promotion that you signed off on. Why did you sign off on his promotion without further review? Because it looked like there were other incidents and concerns that had occurred prior to that period. It almost looks as though, that maybe wasn't something that had been taken into account for his promotion to go through.
So I was, I think, 2 weeks on the job, if you look at the timing of when I signed, and it was the recommendation by the outgoing Deputy Secretary of Operations, as well as the acting Deputy Secretary of Operations, as well as the acting Chief of Staff at the time. So I had 3 people at the time advising me to sign that he was a good leader, had been with the MDH for quite some time, and would do a great job. And being new to the role, yes, I did sign based on 3 people advising that he would lead the hospital very well.
And these 3 people were from the prior administration, right? So was there anyone
Correct.
else that you consulted regarding this before signing off on that?
There was no one else that was anyone that I had hired, because everyone was so new. So either people had left or they were from the prior administration, and I was too new to bring on my own team to do my own vetting.
Then what was the urgency in signing off on this promotion without waiting for,
I agree with
your own
you,
team
and
to come in?
I agree with you, and I asked that question, and they said, well, we have a lot of vacancies to fill, and so I agree. And in retrospect, could I have waited? Absolutely. But again, hindsight is 2020.
Okay. There were a lot of other concerns that have been brought up. I mean, and we had heard from Disability Rights Maryland that there were numerous letters sent to you directly about various incidents that have occurred, and multiple patient deaths. And my understanding was that DRM had the opportunity to meet with folks at the department, or folks at Perkins regularly, and that has since ceased. And so the incidents were brought to your office's attention. Was that something that you had seen or were aware of?
So I'm getting the letters from Disability Rights Maryland now because the facility reports to me directly. So I get all those letters now. I was not getting them before. I have one anonymous letter that I received in December of 2023 that was investigated. And again, the investigation that was done by the prior leadership that is no longer with the department came back with no findings.
Okay. I guess back to Dr. Moran for a second. The Post had also reported that that you had reviewed and toured Perkins in December of 2023, and that there was no concern about the performance or reporting structure there. Nothing was brought up per the reporting that took place about concerns with Dr. Moran's, reporting back to you.
Well, again, I had a very staged tour, as I will say, and I would imagine in your role, when you come to places, you get a very staged tour. And so that is unfortunately what I got when I went and saw Perkins.
Given the level of concern, did you not request an opportunity to speak to other folks or have a chance? I mean, you're the secretary. You can come into that facility whenever you want. Wherever you want.
So I can come in whenever I want, but I don't have access to the building like that because it is a full lock facility. So I still need someone to bring me around. And so I did ask to speak to individuals. And again, I was in a place and open and I didn't have leadership. But the people that they brought to where I was were still handpicked people, unfortunately.
Okay. It's disturbing that, with hearing all these concerns and problems at Perkins, and it seems like some of this had percolated up to you, maybe not to the degree because folks were misleading you within your staff, but to not have the chance to speak with other folks, to tour it without getting the stage tour, I think is really a bit of a disservice to understand what's taking place there. And that I think is, hard to fathom after all this has occurred. I think the other, go ahead.
Go ahead. So I don't disagree with you on as much as you think should have been coming up to me was not coming up to me, which is why I have removed that whole middle layer, and the facilities have now come to their back to direct report. So I now meet with the facility directors. We're now standardizing org structures. There's review of policies and procedures. So the whole thing is very, very different for all the reasons that you are stating.
I get that, and I think that's an improvement, but why did it have to get to this point where there have been multiple patient deaths, rape, assaults, a riot, for all of this to finally occur? I mean, there was a lot here before this finally bubbled up to a point where there was a proper organization of the structure for reporting back to you. It just seemed like it took a really long time, and there were other warning signs that appeared that they weren't really addressed or heeded earlier.
So again, things were bubbling up to me, and I received a very, very broken agency. We just talked about OHCQ and all that needed to be fixed. And I could go administration by administration about the amount of dysfunction, the vacancy factor. And I was systematically working through all the administrations to fix and staff up in the areas that needed to be addressed. So I had to rely on leadership and what people were telling me. And so it was just took a little time for me to figure out that I was not being told the truth. And when I figured that out, we started making changes in leadership and expectations and reporting requirements.
So I appreciate that. I think the post, though, brings up an important, I think, point, that there was a letter that was sent to you by one of the providers at Perkins in December of 2023. And, it was very ominous. I mean, it stated that, they're hoping that somebody will solve and correct this problem before something terrible happens. It outlines multiple incidents that have taken place here, and staff's safety who have been put at risk, other patients whose safeties have been put at risk as well. This letter went to you, was CC'd to the governor and a bunch of other folks at MDH. Was this a letter that you saw back in December of 2023?
I did, and that was the one that I asked for a full investigation on, and that was the investigation that I got back was no findings. That the findings couldn't be corroborated. That's what I got back as the result or the outcome of the investigation.
So you got this letter with some very serious allegations in it. You turned to staff to ask for a review and investigation, and you were told that there was nothing here and nothing to look at, and that was it.
That's what right? I can't do the investigation. I have to leave it up to the people that do the investigations. So I left it up to, there were HR issues in there. There were security issues in there. So it was a team of people, each to address some of the complaints that were in that letter. And that's who I left it up to do the investigations. And what I got back was they couldn't corroborate what was in the letter.
And you took them at face value, even though there's some very specific things in this letter, all the way down to like specific contraband being found, dates that are listed in this letter, names of security individuals. You took the follow-up at face value.
I mean, I can say it over and over again, Senator Lamb. Yes, that's what they gave me. And at the time, that was the information I had, short of doing the investigation myself, which I was not qualified to do.
Who did you have lead the investigation?
People that are no longer with the department.
Was it Dr. Moran?
No, it was not Dr. Moran.
Was it folks in Perkins?
No, it was not people in Perkins.
The Post reported that it wasn't until months later, after the Post brought its findings to all of you at MDH, that you began personally investigating this matter. What do you have to say about that? Because that seems like a couple months of lag, because this article from the Post is referencing that it wasn't until May of 2024, several months after this December letter, that you started looking into this further.
So no, we had already started investigations, but we went back to some of the cases that you were just referring to, and that's when we went deep on some of the cases and the reports that I had gotten and the emails that suggested it was one thing. And that's when I, like, for example, the clinical record, and I asked for the clinical record to look at it myself, that kind of work. So that did happen as a result of the May, the Post reporter, but we started investigating some of the activities in February, earlier. Can
you explain why there was a difference in how you investigated these activities in February and what investigation took place after the December letter? Because what you said with the December letter is that there was investigation that took place. Some folks at MDH that were not in Perkins did this investigation, reported back to you that there's nothing here, nothing to look at. And then fast forward a few months to February, you just said that you started looking at this more deeply.
Because of the personnel action, because of the activities
The
specific
personnel action being the restraining order?
specific to Dr. Moran.
Those personnel,
So I can't get into the specifics of the personnel, but some of the activities that were happening were very alarming, that caused us to, or caused me to look further at other things.
and I'm not asking for the specifics and not the personnel records, but like what came to you that was different than what came to you in December? Because in December, you turned to staff and asked them to look into this. They came back and said nothing here to look at. In February, something came to you that made you look into this again more
So
deeply.
in December, except for the letter, none of the investigations were coming to me. In February, I was actually being CC'd on things directly. So I could see the email threads, I could see the activity, I could see the responses. It was very different. I was now being included in a way that I wasn't included before.
Internally, you mean among staff?
Internally, correct.
Okay. Let me pause there. I know Chair Attar has a question. Turn to her. See if
Thank you, Chair Lamb. So Chair Lamb covered a lot of my concerns. And I know for time purposes, I'm not going to repeat those. But I do want to touch on one thing. We keep using the words you were misled, misrepresented. I think this sounds more like a cover-up rather than being misled or information was misrepresented. This sounds like a total cover-up. And I know you mentioned those people are gone, but originally you were talking about how the cover-up came from the top, and then went all the way down to specific employees that they had to speak to you. Is there anyone that you know that was involved in this cover-up that is still working there now?
And can you assure that everyone that was involved in this cover-up is no longer there now either?
So no to your second question, because I can't fire my way out of, so no to your second question without decimating the facility. And so unfortunately, additional actions requiring having leadership in place at Perkins before subsequent actions can happen.
We're talking about here, for example, a homicide was covered up. When you're saying you can't fire your way out of it, if you have an employee who's still there right now and was part of covering up a homicide, how can we say that person is doing their job correctly and not hurting others while they are there? And how long is it going to take until everyone who was actively part of this cover-up is no longer there and putting others in harm's way?
Well, so I don't know it as a homicide. You're labeling it as a homicide. It was a death in the facility, but to my knowledge, it's not been labeled as a homicide. So maybe you have information that I don't have.
Okay, so let's change it to death.
It seemed like a death based on negligence, though.
That's not a homicide.
It can be a homicide by negligence, but let's put that aside for purposes of, let's just use the word death. A death, the cause of a death was covered up. And what I'm hearing is that individuals who were part of this cover-up, it wasn't just misleading information that was given. It seems like there was a full cover-up to make sure you and maybe others weren't aware of what's actually going on. So I hear what you're saying. I just want to point out that that is a concern, and I'd like some follow-up to find out if you can look more into it, what can be done to make sure, if you can't answer it now, I understand, but what can be done to make sure that those individuals involved in this cover-up are no longer employees. And I want to point out that, again, it wasn't just this death/possible homicide. There was also a rape, there was also a riot, and all the other things that Chair Lamb mentioned and that we've seen that's taken place, that it sounds like everything was covered up, not just the death. Okay. Chair Lamb, did you have anything else? Doesn't look like
Yeah, I mean, was there anything else that you wanted to touch on?
No, I'll leave it there for now. Thank you.
Okay. I did have other questions about staffing, and you know, it struck me when you looked at the chart that you showed where staffing seemed to have improved and then staffing all of a sudden went down. It seemed to also coincide with when Dr. Moran arrived at Perkins, that in 2019, when he arrived there, that's when the numbers started going down. And, you know, I know staffing is a priority. Was that not something that would have triggered your attention or further attention, given that those numbers kept trending downwards and people were leaving? And is it not the standard practice of the department to do exit interviews of these individuals who left, who may have highlighted some of the reasons sooner for them leaving?
So it is the practice of MDH proper, but what we learned is that the facilities were not doing exit interviews, and it's certainly now under the new HR director for the policy for all facilities to do exit interviews. So unfortunately, it was not the practice of the facilities to do exit interviews, any of them, not just Perkins, but they're doing them now.
Okay. And so the trend data that we saw in that graph that you showed earlier, that was not something that had been brought to your attention sooner.
No, I don't think under the prior administration it was looked at, and we started looking at it only recently across our facilities, looking at the vacancy factors across all the administrations. So it's something that we track now, but it's not something I had when we started here. It's something we built to track vacancies over time.
Mm-hmm. Okay.
And we didn't just do it for Perkins. We do it for all the administrations, all the facilities now, to track as we try our prioritize where we need resources the most. And also to understand leadership, to your point, if we're losing people, why are we losing people? And is that a function of leadership? Is it a function of the work? What is it a function of? So we are looking at vacancies a little bit differently, not just vacancies, but if turnover is high, why is turnover high? Are we not supporting people well enough? Do we not have the right training in place? Is the leader doing something that makes people want to leave? So we are tracking it from that perspective, not just for a vacancy factor. So we built dashboards now that now tracks vacancy differently, and that none of that was in place when we took the office.
And you probably recall or been informed that there was a law that was passed in 2020 that outlined specific security staffing ratios at our facilities, which we are seemingly not in compliance with. How?
So that's true. I will tell you personally, I disagree with the staffing ratios because it's a hospital, and with those staffing ratios, we'll have more security than we have clinicians, and we need clinicians in the facilities because the patients don't have the right programming. And I think if we had the right programming and they had enough programming each day, then they would get the help that they need and the assaults would go down, and then we wouldn't need all the security staff that law passed. So that's, you know, the world according to Laura as a clinician. So yes, and I'm aware of the staffing ratios for security. I don't think that's consistent with staffing ratios in other states, and that's one of the things that the third-party evaluator will have in their final report, because that's something we've also asked them to take a look at for us.
So if you believe that that's the staffing ratios for the security officers at Perkins is not appropriate, are you saying that it's not your intention to heed state law that states current staffing ratios?
No, that's not what I'm saying. I've asked them to look at and evaluate all our staffing ratios, clinical staffing ratio and the security attendant staffing ratios.
Okay, but we're not meeting the security staffing ratios that were actually outlined previously in the law. And
we are staffing up. I gave you the staffing. It included security attendants and the job fairs that we have had. So we are staffing up all the open positions that we have. So the numbers that I gave you were staff successfully interviewed 68 security attendant nursing candidates. So we are interviewing and staffing up people who say yes. And there were 13 appointments pending for various stages of reference and background checks. That last slide from the job fair. So the team is actively hiring for the open positions that we have.
so that's helpful to get a sense of the direction we're moving in. But you know, I guess looking at it from the opposite direction, how many vacancies do we have remaining?
I'd have to pull it based on all the job fairs we've had, so I can get you an updated number now. I don't have it with me in front of me. So, but we can get that and report back.
I guess to follow up on Chair Attar's questions about the cover-up here. Obviously, a cover-up is very disturbing, and it seems like the reporting that's taken place and what's been described certainly sounds like a cover. You know, I think what I find really concerning too was that it seemed like there was actual intention there, that the court, that there was a court subpoena that had been sought by Maryland State Police to have the videotape of that individual patient who died, and that the tape was never retained and allowed to be overridden after 30 days. And that sounds like an active cover-up by individuals that are there. What's your reaction to, you know, does that sound like does that sound like a cover-up to you? And B, you know, can you assure us that those folks were involved in that incident or no longer there as well?
So I don't know.
That's basically tantamount to destroying evidence.
I don't know who was involved with that. I don't know what our policy is for storing film and for how long. So I really can't comment on that. I'm clearly not an expert on security policies, so I don't know the answer to your question.
Okay, but just to be clear, there was a court subpoena asking the facility to retain those.
But I don't know how long after the court subpoena came. I don't know what our policy is for retaining film. I don't know, is 30 days reasonable? I don't know if I don't know the answer to your question. So I don't know how long after the subpoena came, and what the hospital policy is, if there is a policy.
Well, at a baseline, the policy of the facility to heed court order, right? So the court order for subpoena was to retain these records. And I think the Post's reporting showed that there was at least 2 weeks before the 30-day mark at which the recording would have been overridden, that the leadership at Perkins received this court subpoena to retain these videos. And so there was at least a 2-week notice ahead of time that could have taken place for these videos to be retained.
So I don't know the specific issue around the videos, and I did not read the details of the Washington Post story like you did around the video, but I'm happy to follow up on that and get back to you. I really don't know the details of that specifically as well as you do.
Okay. It was similar to this issue because I think it has to deal with our mental health, individuals who have mental health issues that are retained in some of our local jails and not able to make it to psychiatric beds. You're probably aware that there was in total at least $1.5 million in fines from state judges who have said over the last year that Maryland has not properly transferred mentally ill defendants who are in some of our local jails to the appropriate psychiatric beds that they might need, and that the state law requires them to be transferred within 10 business days. We have some folks that are waiting weeks or perhaps months of time for that transfer to occur. What is the department doing to actually address that concern? Is it adding more beds to Perkins? Is it asking for more funding to be able to support state psychiatric beds? Because this problem seems to be ongoing, and it seems like there's no improvement in sight, even when state judges are still continuing to fine the department.
I think it's a very complex problem, and I don't think it's a problem that the department can solve by itself. I think we absolutely need everyone at the table to help solve the problem. And as more mental health courts come online, I think the problem is going to get worse. The number of evaluations and the number of court order placements exceeds the total capacity of beds that we have in a year. As I've already said, the criminality and the acuity of the patients is way more complex, so they're taking longer to treat, and so length of stay has gone up, and so the expectations, even if we build more beds, we would exceed capacity. Our waiting list as of yesterday was 229. That's the waiting list, and so there's got to be a different way to think about some of the clients that are on the list, such as the misdemeanors that are timing out of their charges. Those are people that could be treated in the outpatient setting, and how do we support them differently than putting them in the system and having them get on the waiting list. We also have people that are waiting for discharge, and we're not getting timely responses from the judiciary, so beds are being tied up. We also have problem with discharges, so there's still patient choice, and in some cases, people are refusing to go to the placements that we identify for them. So it's a very complex problem that can't be solved with MDH alone, and building more beds is not the answer. I will also say, given the fiscal climate and how long it takes to build capacity, it's not an immediate solution either.
So, I mean, there are a few things that kind of stood out in what you just described. One, a lot of it was a description. It was also a concession that there's, that this problem will probably get worse. Right? It sounds as though the hole is getting deeper, and I don't know what that means for the state. Will the judiciary just continue to fine the department, right? But what I haven't heard is a plan, and that it's complex. It requires a lot of different folks coming to the table, but it sounds like there's no plan to address this.
Well, so I'm ready to come to the table with a plan. I have to get everyone else to come to the plan, right? The plan doesn't just involve me. So for instance, again, can we treat misdemeanors a little bit differently than the way we're treating them right now? So that's one. AOT is going to give us a new tool in the toolbox to deal with those misdemeanors. That's another tool in the toolbox as an example. As we think about discharges, how do we build capacity? That's something that we're absolutely looking at. We have public defenders, we have an evaluation, we say they're competent. The public defender says they want another opinion for a different, for a new evaluator. They get another evaluator that says they're incompetent. So the judge goes with the second. In clinical, you know, in clinical care, if you have a different opinion, you go to a third clinician, right? To figure out, well, which is the right opinion. In here, if we get a second opinion on an evaluator and they said they're incompetent, then that's the case that we go with, even though we had an evaluator say they were competent to stand trial. So now we have, time has lapsed. Now we have a public defender asking for an evaluator. Now they're saying they're incompetent. They get added to the list. So there's multiple points where somebody else that's not controlled by the department gets a say in the system for another evaluation, another opinion, and that adds people to the list. So everyone has to be at the table to think about the piece that they own and how that contributes to the list. So I can talk about what I think we should be doing as MDH and how to decompress the list, but I'm not the only one that contributes to the list. In fact, I don't contribute to the list at all. All I can do is help move the list based on who's in my facilities.
Well, the moving of the list is really important, right? Because this is the health and well-being of those folks that are in our local prisons that don't have access to care otherwise and actually need a lot of help. But I certainly understand that it's complex and recognize that there are a lot of stakeholders that need to be a part of a discussion about the solutions. But who is taking the lead on bringing these stakeholders together to move to a point where we can find some solutions, actually have a plan to address it so the department is not being continuously fined?
I actually had this discussion earlier this morning with Chair Pena-Melnick and whether we could work with Chair Clippinger. I saw Chief Justice Fader yesterday at State Circle and asked for a meeting with him just yesterday to discuss this issue, and got a call where we were on this discussion with Chief Justice Morrissey to sit down with him as well. So I'm reaching out to the people that I think have some say or could guide a process or at least bring their stakeholders to the table to have a discussion, but certainly welcome your input and your role in leveraging your office to help bring people to the table. But I think it's that kind of effort that's needed to get everyone to the table to help solve this very complex problem.
Okay, so we're still kind of in the exploratory phase. We don't have a plan yet working with it, I guess. In the meantime, we still have a backlog that probably will get worse.
Yes,
And
that's what I think. When I started here last year, there was about 150 people on the wait list, and the wait list is 229 as of yesterday.
And these state judges have no other recourse. I mean, their only enforcement mechanism is to fine the department. They can't go out and bring some of these patients out and make a bed.
10 days was an arbitrary rule at the time that they set the rule. That's all I can say.
So you think 10 days is unreasonable?
Length of stay, we don't get patients in and out in 10 days. It's just much more complex than that. So, and if you have evaluations and you're deeming the number of people deemed incompetent is way more than the full capacity of the system, no matter what, I'm always going to have a waiting list.
Doesn't that point to the system being under capacity though?
Or you're deeming too many people incompetent.
Well, we don't choose how many people decide to become incompetent, but we can choose how many beds we want to make.
Well, we have people, as I've said before, that are sometimes deemed competent, and then a second opinion comes in and deems them incompetent.
I mean, I think those are probably limited circumstances. I don't think the vast majority of the folks that are incompetent are actually being misdiagnosed as, being incompetent. And my understanding is that we do have beds that are in our state facilities like Springfield and others that could total up to 100 beds. They're just not staffed. Is that
That's not accurate. Nope, that's not accurate.
So can you clarify that?
The only way they're not staffed, again, back to the acuity, we don't have extra staffing and some people require 2-on-1 support. So that's the only way a bed might not be staffed is because we have to have 2-on-1 supports.
So are these empty beds not empty beds, or are they beds that are still waiting on staff to be able to open up?
When I look at our census, the only time a bed is empty is just waiting for the person to move into the bed. But on any given day, we are full.
I don't think I meant like empty beds as in beds that are staffed that are waiting for a patient to come. I meant that there are units that are shuttered in our state facilities that actually have physical beds that aren't open because there's not staffing there, that there are old units that may be available to reopen if we had the staff to do so.
Maybe you can educate me then on what those units are if you know something I don't know.
Okay. It's stuff that I heard from our labor representatives. I think they may be able to speak to that as well. But that's also my understanding that there are some units that could be physically opened. There's just not the staff to be able to staff those beds, and that those facilities are probably certified for those beds as well, that they could open them if they had staffing. But the rate limiting step here is the staffing. And, I guess just to clarify the piece on AOT, that AOT can't be used for criminal offenses. And so, that at best is a tool that can be used prior to arrest, but doesn't help in the instances where a defendant is found incompetent by the courts.
So I will give you a perfect example. Last year, or earlier this year, before the AOT hearing, I was asked to be in court for another case. The public defender was late, so they took the next case, and it was a young man, probably about 24 years old, who had a history of schizophrenia, was in court for follow-up of charges of urinating in public, loitering, and I think he might have taken something from the 7-Eleven or like a kind of convenience store. And he was in treatment. He was mostly taking his medicines pretty well, but not 100% adherent. And the judge asked him a series of questions, all of which he answered appropriately, alert and oriented ×3. He had already been deemed incompetent, but was doing what he was supposed to be doing really, 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 really well. And then again, the judge asked him, an adherence question, and he answered honestly. And she said, well, I'm going to uphold the decision for incompetence. And he said, but judge, I'm doing everything you told me to do. I'm not doing it perfectly, but I'm doing it better than I've ever done it before. And I'm committed to doing it. Just let me stay home. Let me just stay in the community. And she deemed him incompetent anyway. So that is someone that was doing well on the list, that was better than he'd ever done before, had misdemeanor charges, and now is on my waiting list, or was put on the waiting list because he was deemed incompetent. That's someone that absolutely would have benefited from AOT if AOT was available at the time, and he was already taking his medicine. But that's an exact opportunity where having that as a tool in the toolbox would help this young kid that was probably about 23, 24, at least to my eyes, And again, he pleaded with the judge for a different decision, and that's not where their judge landed. So I'm just saying there are cases for individuals that don't belong on the list that would benefit from treatment on an outpatient than being deemed incompetent and on our list, that are charged with misdemeanors and sometimes with felonies that are of a nature that could still be treated with supervision in the community. And we just need to explore what are those options. And there are models in other cities, such as Miami, which many of us went and looked at, myself, Delegate Chair Clippinger, Senator Smith, Chief Justice Fader, Chief Justice Morrissey, Chairwoman Pena Melnick. We all went down to Miami to see the Intercept model. So there are other cities and states doing this incredible work, but it takes everyone having a seat at the table, thinking differently about the pieces, including the public defender was there, Natasha Dartig. We all went down to Miami to see the Miami model. And we just have to rethink each of the way we operate today if we're going to have a model that successfully meets the needs of Marylanders. But we can't have just the department or just whoever trying to change something without everyone willing to say, okay, we are all going to do things differently so we can all be successful. And that's what it's going to take. That's what it's going to take. And there are cities and states that are doing it.
Okay. Well, would really press on some urgency here because this is continuing on, obviously, and having the right stakeholders to have a plan, at least moving forward. I understand complex process. There are a lot of folks involved. There's no easy solution here, but we need to start with at least a plan to move forward. And I'm not sure, it doesn't sound as though we're at that point to even have a plan. We're still in the exploratory and kind of formulative stages here. I see Senator Benson has a question. Go
ahead. Thank you, Mr. Chairman. You know what? This secretary just hit the nail on the head. We need to make a list of everybody who is a part of this process. Everybody needs to come to the table. She just made a superb suggestion. Mr. Chair, Madam Vice Chair, I'm going to ask that we bring everybody. We've got to feel there's a gap here, a big gap. And the burden is being placed on this secretary. I'm telling you all, it's an overload. Now, I'm going to strongly suggest that we bring everybody into the room to discuss this problem. It is a problem, and there's a tremendous gap. Different agencies are doing their own thing, and that is not what's working. It's not working for us as citizens in the great state of Maryland. It's not working for families. It's not even working for the persons who commit the crime. I'm going to suggest that we do that. That's why I have my hand up, because I think that what this secretary just said is a valid, very, very important suggestion. And from that, we come up with the plan. If it's the plan that's very similar to what you saw, if that works in Florida, what makes us think that it won't work here? Why did we take the trip? I'm trying to figure this thing out here. Let's sit down at the table and come up with the plan that's going to work, where everybody shares a part and everybody does what they're supposed to do in order to make this work. I'm going to put that on the table. I think it's very important that we do this. And I have to tell you, I have people here in the neighborhood that are just, I mean, we just had a horrendous case here last year where a lady, one block down the street from me, had a terrible mental health problem. First of all, the mental health, the county failed her, and then she goes and kills her mother. It's unbelievable. So I think that we need everybody needs to come to the table. And we need to do it soon, very, very soon.
Thank you, Senator, for that feedback. I do agree. We do need to have everyone come to the table. There are no further questions from the members.
And just one follow-up on vacancies, because I know Secretary Grady is going to be coming up to talk about vacancy rates across the state. And from the information that we received from DLS, I'm just looking at vacancy rates across our state departments, that short of the Department of Service and Civic Innovation, which is a brand new department, which, you know, understandably has a high vacancy rate as they get stood up, the Department of Health has the highest vacancy rate of any of our state departments at 15.6% as of October, 2 months ago. Are we making any progress here in reducing that number? Is that trending in the wrong direction or the right direction here?
I think you have to take out all the new pins that we got. If you take out the new pins, it's much lower. It's just the new security attendant pins. The new pins that we got is making it look really high. And we just got those and staffing those up. But when you pull those out, it's not as high.
Okay, these are the security pins for places like Perkins. Is that what you're referring to?
Correct. Correct. So the net new pins and then the conversions that we did. So that's what's making it look high, but it wasn't that high a few months ago. So I think that's what's making it look high right now is the net new pins that we have. But we can get you the number just so you can see where we started, how it's come down, and then with and without the net new pins.
Okay, if you can follow up with those numbers, both with and without the new pins, that'd be helpful. Thank you.
Erin, can you have Melissa pull those together? Thank you.
Yes.
All right, thank you.
Thank you.
Okay, so we can move on now. Thank you, Secretary, to the Department of Budget and Management, Secretary Grady.
Good afternoon. Can you all hear me okay?
Yes.
Okay, great. I am joined this afternoon by some members of our team who I'll quickly introduce. We have Catherine Hackman, our acting Chief HR Officer, Nicole Webb, our statewide EEO Director, and Christina Kaminsky, our Director of Employee Benefits Division. We have a couple other folks on the call or joining in case of questions in particular, but these are our primary leaders on the call, along with Dana Phillips, our Chief Ledge Officer here at DBM. I just want to say thank you to both Chairs Attar and Lamb for inviting us today to discuss our work on several topics. First, we have recruitment and hiring on the agenda, as was just mentioned a few minutes ago. Second, an update on the statewide EEO program. And then third, our efforts to transition state retirees to Medicare Part D for their prescription drug coverage beginning in 2025. I have a few opening comments I wanted to share before I turn it over to the team members to walk through our updates. I'm also very conscious of time, given that it's now past 12, so we'll take direction from you on whether you want us to proceed as we were originally planning or whether you want to cut short any of the particular topics. In particular, I would ask whether you'd like us to start with the Medicare Part D update, which was last on our agenda, but is probably the most critically urgent topic that we're here to discuss today. But I will, again, take direction from you all if you'd like us to do that ahead of the other topics. Before we jump in, though, to the details, I would like to share just a few opening comments, particularly on two of our agenda topics. So the first relates to our efforts to rebuild government through recruitment and retention of state employees, which continues. We have made solid progress, the administration, over our first 2 years, but with a lot more work to do. Catherine Hackman, with her materials, will share more detail, but at a very high level, I just want to share that the vacancy rate within the executive branch continues to move from about 13.4% as of January 2023, when the administration took office, to 10.4% as of November 2024, even with a significant addition of new PINs over those 2 years. So we're adding PINs and we're still continuing to bring the vacancy rate down. As I said, there's a lot more work to be done, more progress to be made, but we are encouraged that we're going in the right direction. The second highlight I want to share on the efforts to recruit and retain staff, our net hires since January of 2023 are a positive 1,800. So we've added 1,800 employees to state employment compared to the 2 years prior to this administration, where there was a negative net 2,600 employees leaving state government on net. That's the net of new additions, net of folks who are leaving. This progress that we've made on net hires is driven not just by new hires, but encouraging to me, we're also seeing separations down considerably over this period. In terms of the other topic I want to touch on before I turn it over to the team to share some details, definitely want to share a little bit of insight on our efforts, as I mentioned, which are very critical to transition our state retirees to Medicare Part D effective January 2025. This is among the top 2 priorities for DBM right now, alongside preparation of the fiscal 2026 budget, and our leadership team is fully engaged in this effort. Definitely want to leave you with an impression of just how engaged we are. We are well supported in this work by our vendor, Via Benefits, which is a Willis Towers Watson company. Through the fall, during this process of our enrollment campaign, we have heard some retirees having challenges with our vendor, and we've taken those concerns very seriously. We've taken those examples very seriously when they come to our attention. But we've also received tremendous positive feedback about the experience with Via Benefits from many, many retirees throughout this process. I'm grateful in particular to a small group of highly engaged retirees who have been sharing feedback with us in an advisory capacity throughout this campaign and this enrollment process this fall. So I wanted to share that with you all. Christina Kaminsky will update you on our progress and the remaining work to be done, as well as our outreach efforts going on as we are now in December, critical time period for this campaign. Personally, I want to ask members of the General Assembly for continued assistance with getting the word out to state retiree communities. It's the importance of them getting enrolled prior to December 31st. Anything that you all can do and anything we can do to assist you in that effort, please reach out. Dana Phillips is our Ledge Director, has been providing continual updates to the members of the General Assembly, and we are here to assist you in assisting us with getting that word out, helping convince retirees that they really must enroll by December 31st. That's our most critical focus right now and for these next few weeks ahead. As I said, given time constraints, I'm happy to take feedback from you all if you'd like us to cover the Medicare Part D topic first, or if you'd prefer that we go through the full agenda in the order that we had prepared and the order that our slide presentation is in.
We can go through the agenda in the order that it is as of right now.
Okay, thank you. With that, then it'd be great if someone could share our presentation, and I'm going to turn it over first to Catherine Hackman to kick off on our discussion of efforts to recruit and retain staff and follow up on our progress with regard to our agenda around rebuilding government from an HR perspective.
Thank you, Secretary Grady. Can you hear me okay? Okay, good. All right. So the presentation, I think someone on staff is going to be pulling it up. I thank you so much for the opportunity to talk to you about our efforts to streamline the hiring process. I'll give you a second just to, I think you have to back it all the way to the very beginning.
If we could start at the beginning of the presentation. If I heard correctly, Chair Attar recommended we go through in the order that we had planned. Is that right?
Right.
Yes.
So that would just mean backing it up to the very beginning.
Yes.
I'm not sure who's controlling the slides. It's a long deck. There's a lot of meaty topics you asked us to update you on. Here we go.
Okay, thank you so much. All right.
Over to you, Ken.
Thank you. All right. So our first slide is just a brief overview of the task force that occurred during the timeframe of August 2023 through November of 2023. The task force met to talk about ways in which to modernize and improve our recruitment and hiring, as well as our retention. We received many good recommendations that came out of that task force. I'll just briefly go over those, just a high level. The task force recommended that we do continuous ratings of applications, that we put into place service level agreements so that we would sort of be able to better track and move through the process of hiring, and just really to hold people accountable to those types of processes. So we were trying to pull back on the number of days that it takes to actually fill a position. On the slide here, the continuous ratings of applications, I assume you all know that generally what would happen in the past is that we would, and we're talking mainly about skilled and professional service positions, those positions by law have to be open for a 2-week period at least. And what was being done most of the time in the past is that recruiters would wait until the close, and then they would get their group of however many applications, whether that was 5 or 500, and then they would begin to rate those applications. And so that was a time-consuming process, and it did create a very large lag in getting the list of qualified people, the list of eligibles, as we call it, to the hiring manager. So we have encouraged, especially after the close of the task force, we have been encouraging agencies to review and rate the applications as they come in. I have been looking in job apps and seeing that that is in fact happening. That does cut down on the amount of time it takes to produce that list of eligibles. So that's, we can go to the next slide. One of the other big things that they asked us to do was to look at expanding the use of open and continuous recruitment model. We were already doing that, but we are definitely looking at trying to do that more frequently now. In that case, there's really no closing date and it just remains open. This type of a recruitment model is most appropriate for jobs that have either high turnover or an immediate hiring need. As the slide notes, those would be things like correctional officers, nurses, and other types of healthcare positions, our family services workers and social workers. They are all like sort of high turnover positions where we have a critical need to hire. This type of a recruitment strategy, one of the things that this task force mentioned and wanted us to look at doing was improving applicant engagement, and using this open and continuous recruitment model can cause some problems with applicant engagement, but we do judge that the benefit is greater than sort of the detriment of it, because it does decrease that time to fill. You can move to the next slide. So again, as I mentioned just a minute ago, one of the task force recommendations was to do what we could to improve applicant engagement. We are definitely still looking at that. One of the things that we did was ask Job Apps, who is our applicant tracking system, our ATS, our vendor for recruitment. They have our online recruitment center, and that's how we receive applications and do our ratings and push out our list of eligibles. We asked them to look at making the texting capability a possibility for us. They did do that in the middle of August. I think it was in the middle of the year, August of 2024. And that has helped us to engage with applicants in a more of a real-time way. Previously, the engagement was mainly through email, which is a good way to reach people. But as you probably all know, texting has become really a very good way of reaching people and reaching people quickly. And so we have engaged with Job Apps to get that functionality up and running. I think you can go to the next slide. I'm sorry, I'm trying to go quickly. I hope I'm not going too quickly. One of the other things that we did that we think helps to improve applicant engagement is we started using video screening. That we did start using that back in 2022 using a web-based application called Spark Hire, but it was so well received by both candidates and agencies that we went to our vendor job apps, and they made that functionality available to us this year. We are currently testing it, and we plan to deploy it to agencies in January 2025. We found that there were some things about the functionality that were not where we wanted it to be for engaging the applicants and making the user experience good or better. So we went back to them, and they are working on that, and we are going to deploy it in the early part of next year. You can go to the next slide. One of the other things that the task force asked us to do was to develop a hire now culture. And that would be a few things, actually. Work toward a common application process so that you could take someone who looks like they're good for more than one job and sort of shop them around to other openings. We are doing that. And in addition to that, we are doing a lot more work in the area of holding job fairs. I think that might be the next slide. If you go to the next slide. Yeah, so and what I want to say about this is I really like to first, before we talk about our efforts on the spot hiring, just mention that really we took a page out of the book of the Department of Public Safety and Correctional Services. They have been really in the forefront of this type of a model, and they've been very successful in doing that. So we saw their success, and with the encouragement of this task force, we hosted 2 job fairs this year. Those were very well received and well attended. One was in May and one was in November. We intend to do those in the future. And what happens there is we actually have agencies that come, they talk to applicants on the spot. If they have to do any type of background work, they will have to get a conditional offer, but there is an opportunity to actually hire on the spot. And even OPSB was advantaged by this. We actually hired 2 people on the spot in one of these job fairs, very successful individuals who are really great members of our team, and we're seeing good results from that. So we are currently looking at trying to track how many of the people that come to these fairs get hired, and we are working on that. I don't have the stats available to you right now. I think we will have those in the very near future. And we're just sort of analyzing how much bang for the buck we're getting out of these fairs, but they are being well received by the agencies and the candidates who are attending. You can move to the next slide. We were also asked to expand career ladders. So we're doing a couple of things in this area. One thing we're doing is we're looking at our current classifications and looking for ways to add on the front end and on the back end of series. So looking for ways to have sort of trainee level positions where you can come to the state and work without a ton of education, but maybe you have experience, or maybe you have no experience and you come in as a trainee and you work your way up through a career ladder. We feel like that's not only a good way to attract good talent, people who may not have had the opportunity to go to school, but they certainly have talent to do the work that we need to get done. And they stay with us because they have a progression available to them all the way up through, a good paying position at a higher level. And so that's helping us with our retention. We're also doing a lot of things in the alternative career pathways. We are working with the Department of Labor, and we're actively engaging with the unions on positions that we could put in an apprenticeship model. We have 2 apprenticeships that are very close to going live, essentially. In fact, one actually is up now on the Morgan State website. That particular one is an environmental health apprenticeship. And if you would like the link, we can get you the link to look at it on their website. So how that's working, or how that will work, is Morgan State students will enter the apprenticeship program. They'll do their regular coursework through Morgan State, but they'll also take training with an MDH instructor, and they'll have a job with MDH. And so they'll, make money while they're learning. And I'm sorry if I'm going too fast and you're trying to keep up with me. And then the other one that we're working on is the DGS procurement apprenticeship, which is going before the Apprenticeship and Training Council in January 2025. This is the first ever public procurement apprenticeship. We're really excited about this because I'm sure that you're very well aware that procurement professionals in the state of Maryland are few and far between, and they're hard to keep, and they move around a lot. And so it's a very complex area. So we're hoping to get people in early on and keep them throughout their entire career. Let's see, try to move quickly. Let's see, I'm so sorry. Let's see. So I think maybe we should move into the vacancies. As Secretary Grady mentioned, you know, we have been publishing out a dashboard. We publish it out each month. The dashboard goes over the number of agency pins, the number of statewide vacancies, the vacancy rate and net change by agency, numbers of terminations and retirements, the number of contractual conversions, the time to fill, and the number of contractual employees who have been on contract for over 2 years. As Secretary Grady mentioned, in January of 2023, the vacancy rate was 13.4. By the end of January 2024, a year later, the vacancy rate had dropped to 10.10. At the end of November, we just published out the new dashboard. The vacancy rate increased slightly to 10.4, but over the calendar year 2024, the PIN number increased by about 1,643 PINs. The next slide is really just a presentation that shows what the dashboard actually looks like. I believe we're supplying it to DLS, but this is really the dashboard. This is the monthly dashboard. I'm sorry, it's very tiny print, but just wanted to kind of give you the look and feel of it. I wanted to just also mention a couple of things that, you know, Secretary Grady just recently said to me, what gets measured, you know, gets fixed, changed, improved. And I think that's very true. We've been really pounding on agencies about the contractual employees that are been employed over 2 years. We've put in place an additional layer of review at DBM, which I think is has been very useful in helping agencies to sort of rethink what they're doing with contractual positions. And we've actually seen a huge decrease in the number of contracts over 2 years, and an even bigger and more pleasing increase in the number of people who contractually convert. I believe that I did the math on that, and I think we went up about 46.5% in contractual conversions in calendar year 2023, we had 574 employees who contractually converted. And then so far through November 2024, we've had 841. So that's a 46.5% increase. Really pleased about that. I think the next slide, or the slide after the next, I'm sorry, the next slide after this one, the committee had specifically asked if we could sort of call out what agencies had hired. So I picked the calendar year to date. And so on the left hand of the slide, this is showing you who's hiring and how many they've hired. And then on the right hand of the slide, that is who has contractually converted employees, which agencies and how many. And that gets you to the total that at the end is 841. That's actually to date, the calendar year to date. The next slide is, or the next set of slides is concerning the service contracts. I think you last year had a briefing on this. I think Cindy Colner handled that briefing just to talk about the service contracts. I think through the process of being asked a lot of questions about that, we looked internally and also worked to improve, to make sure that DGS, who's getting those requests for these procurements, is working with us, and we're working hand in hand now, much closer, and we are getting way more reviews. I think in calendar year 2023, I think we had one that we reviewed, and then, or approximately one per year in the previous years. This year alone, we have reviewed about 13 of them, and those contracts were all determined to be exempt under Title 13, Subtitle 4. An exempt contract means that state employees are not available, or there's a conflict of interest for state employees to perform the services. It's an emergency of some type. It's incidental to some other type of, maybe like a leasing arrangement, that type of thing. So we have had requests from MIA, from MSDE, from the Maryland Department of Health, the Maryland Transit Authority, DGS, DJS, the Maryland School for the Deaf, Public Safety. I think I covered all the ones. So we have had 13 total. requests over this year so far. During this year in fiscal year 2024, we had no service contracts that were determined to be non-exempt from the preference, which of course is the preference to hire state employees to perform state functions in state facilities. And with that, I'm happy to answer any questions you might have.
Thank you. Are there any questions from any of the members? I don't see any hand raised. Let me just check one other place. Chair Lamb, I saw you unmuted yourself. Did you have
Yeah,
anything?
I do have some questions, I guess, with regards to the vacancies. You know, I guess the question is, you know, we obviously still have a fair number of vacancies here in the state, and when we look at it, we also are facing obviously a significant budget crisis here. So is the intention still to prioritize the filling of these vacancies to the degree that we are, which, you know, I think is important, or is there going to be a deprioritization to help with some of the budget challenges that we're seeing?
Thank you, Senator Lamb. I can take that question, Catherine. So as you know, we are working hard on the governor's budget proposal for fiscal 2026, which will be scheduled to be introduced January 15th. What I can say, it's a good question. And of course, when we're managing the need for staffing alongside managing, you know, extraordinary budget challenges such as are before us today, I think your own DLS reported the absolute greatest general fund budget shortfall in at least 20 years, including the Great Recession. That becomes a balancing act between bringing on new staff, new structural expense, alongside working to close and balance our budget. But what I can say is that at this point, you know, agencies are continued to be authorized to recruit and fill roles. We do not have an across-the-board hiring freeze in place. We do have, you know, we encourage agencies to be managing within their budgets. And when they are seeing areas that are, you know, growing beyond budget, we rely on them to manage appropriately and to prioritize, you know, all of their expenses, whether it be additional hires, whether it be new contracts to be let, or purchases, procurements, et cetera. And we depend on them to do that. But there is no across-the-board hiring freeze in place today. Obviously, we are working through our plans for next year and not prepared today to share details of what the governor will roll out in January. But the administration's commitment to rebuilding government, to recruiting and retaining skilled workforce remains among our top priorities.
So I guess you can't rule out a potential hiring freeze to address our budget challenges.
We have not chosen to roll out an across-the-board hiring freeze to date. That's a, you know, it's a decision, a policy decision by the administration. We have not gone there. We are continuing to recruit new staff across all agencies. We are absolutely prioritizing, you know, among based on as managers do every day in any organization, but we are not freezing hiring efforts. I think my view would be that it's somewhat counterproductive long term to take actions such as across the board freezes in light of our need to deliver government services to people. I hope that's helpful context.
Yeah, no, I mean, I think filling vacancies is important. I agree that it needs to be a priority. And so, you know, I certainly understand the budget environment right now is complex and it's really challenging. And, you know, I'm a little bit wary of the fact that, you know, that this could be deprioritized and this could be, you know, a way to address the budget shortfalls that we're seeing through a hiring freeze.
I would encourage you to give us some grace. January 15th, the governor's budget plan will be revealed. I think I've been clear about what our priorities have been to date. At this point, you know, we continue to prioritize staffing our state agencies appropriately to provide the services we need and to ensure secure and safe environments for both our clients and our workforce. And at this point, we are not rolling out, any changes to that overall prioritization.
Mhm. And then a
And
question
say at
about,
the moment about the upcoming budget.
okay, understood. Yeah, we have about 30 days to wait on that, right? So I know you're all actively working on it. What was mentioned at the top was this task force. I know there was a report that came out from the task force. I think, Secretary, you were part of the task force, as were a few other senior leaders.
Many members of my team were.
Secretaries were, participating in this. What is the next step? Is there, something that's who's gonna take the lead on implementing some of these recommendations from the task force?
So thanks for teeing that up. I think I mentioned in our last hearing in October that we are in open recruitment for our chief HR officer. This would be an inaugural chief HR officer for the SPMS. We did make a hire in September that, unfortunately, due to unanticipated personal circumstances, had to resign fairly quickly after accepting the job. So that set us back a little bit. But we are in open recruitment. We are interviewing, and I have some optimism about the candidate pool. And so, I do look to this chief HR officer who we're bringing on board to, really champion and lead our efforts going ahead. I think Catherine did a fantastic job reviewing much of the progress that we are making and continuing to make. And I'm incredibly grateful to this team to be continuing to make progress and focusing on our goals, even when we're, relatively short-staffed ourselves, particularly in that top role. But I'm also incredibly eager for our next leader to come on board with the vision that we all have around the opportunity here and seeing this through in terms of all of the real opportunity that the task force pointed out. So I hope to share some news on that front soon, maybe the next time we're together.
So you think it's going to be a responsibility of the new chief HR leader that you bring on?
Priority for the new chief HR officer. Yeah.
And is there any need, or do you sense that there's any need for legislation? I've skimmed through the task force report, but curious if you have any thoughts on need for legislative changes, or is this something that could be all implemented by the department or in coordination with others?
Question. And we did collaborate with at least one or two legislators last fall around, potential legislation and what might be helpful. In the end, I think the task force came away from their deep review with a view that at this point, we don't see significant need for legislative changes when it comes to our recruitment processes, et cetera. We believe there is a lot we can do administratively. And in terms of technology improvements, et cetera, that again, I'm very eager for this chief HR officer to lead for us and champion. That could change over time, and particularly as we bring a new leader on board. So we will continue to be in touch with both subcommittees and are happy to continue to talk through ideas on your end with regard to changes that you think might be helpful. At this point, there's nothing in particular that we're prioritizing for this session.
Okay. Last question then, I guess, is in looking at the graphs that you had, looks like a kind of, you might call it a dashboard, with these numbers and such. There was a bump that we see in June of 24, kind of across the board on some of these. What do you attribute that bump up to?
Yeah, and you might be pointing to July 24. Is that what you mean?
Sorry, right. It's the next
month. The bump up in
June was the valley.
Yeah, and that's exactly what Catherine referenced. So that's the addition of new PINs with the new budget year. What I can share on that front is, as I mentioned in the opening comments, so the progress we've made on vacancy rate is even more meaningful in my view, given that we've added tremendous number of additional PINs just in this administration alone. The fiscal 25 budget, which began that July, that you're looking at, added 1,223 new PINs to the executive branch, plus an additional 900 contractual conversions on top of the new PINs. The prior budget, our first budget, fiscal 24, had added 476 new PINs. So when new PINs are added with the new July 1st budget year, the number of PINs automatically increases. Many of those PINs, even many of the contractual conversions, are vacant when they hit our books. Therefore, they are showing up in vacancies. This is similar to what Secretary Herrera-Scott was describing with regard to MDH specifically. I can share that MDH in particular, just following up on that, received 390 new PINs in the fiscal 25 budget. So of that bump in July, 390 new PINs, plus an additional 559 contractual conversions were within the Department of Health alone. I hope that makes sense.
Yeah, that's helpful. All right, thank you. Looks like Delegate Harrison has a question.
Thank you. Good afternoon.
Good afternoon.
Just a quick question. Over the last few days and, actually over time, we hear about, the number of vacancies and trying to staff up. And what I've heard over time is the amount of the time that it takes between an individual making an application to having an interview to having an offer made. Could be quite some time, and then actually the onboarding process. And then in all of that time, they've been offered another job, outside of government. They take that because one, it may pay more, but two, because of the time. Have you, and I'm not sure if you addressed this, I may have missed it, the cutting down on the time, or getting people hired quickly and getting them in place. How have you addressed that? Do you plan to address it? Because we do have so many vacancies, and every agency says that they can't do what they need to do because they don't have the staffing. And so just moving that staffing and increasing that staffing at a much more reasonable rate.
Yeah, thanks for raising that. I can start by just saying one of the metrics that we do track on this dashboard that Catherine shared is the average time to fill. As of November, we're down below 100 days, which is actually decent progress for state government, at least during my time here. We've been up around 120 or above, I think, for much of the last couple of years. So it's encouraging to see that starting to come down a bit, but there's a lot more work to do, and absolutely agree with the comments you've shared. I think, one thing I would say is that Catherine's presentation talked about a number of the strategies we've been using, particularly since the task force reported out its recommendations, things like continuous posting, things like the video interviewing, as ways to try to help agencies speed up the recruitment time period. But we have a good bit more work to do to help our agencies use these tools, know how to use them. Much of this comes down to just working with the agencies through what the problems are, the biggest challenges, tracking the data agency by agency and even classification by classification to know which roles are taking the longest and how can we tackle, breaking down those process log jams. I'm going to ask Catherine if she wants to add to this. I tried to say, we've made some good progress on some of the strategies the task force identified. We have a lot more work to do. This is definitely an area of expertise that we're looking for very closely in our chief HR officer candidates who we're engaging with right now. But Catherine, do you want to add to my comments?
Just to say that I agree with you. We have made a significant amount of progress. It sounds like just days, but actually it was roughly maybe like 19 weeks in general. And now we're down to about 14 weeks, which is a lot. 2 weeks of that is typically, because most of these jobs are skilled and professional service, that's a mandatory at least 2-week posting period. So what we've been looking at is ways to sort of collapse that by having agency hiring managers, because remember, this isn't all about the recruitment professionals. This is also engaging the hiring managers to do their piece, which is typically putting together the questions that they need or want for their interviews, gathering people together to get their panel together, getting all that approved. And we're trying to push the agencies and try to collapse that so they're not waiting. Oh, now I have a list. Now I'm going to look for people to be on my panel. Now I'm going to try to find time to put the interviews on my schedule. And we also just, by the way, are also going to be recruiting or are recruiting right now for a new recruitment and examination director. And so that's another individual that we're hoping will come in and help us with fresh eyes, take a look at the process that we have available to us and looking for ways to leverage technology to shorten the time frame. We do recognize that there's some room that we want to move. We want to get below, I'd like to see us get below 10 weeks. I think that's very difficult, but I think it's doable. Thank you.
One other question, just for those positions that may require background checks. I know that they tend to take a little longer. Is there any headway on with the investigations or whatever it takes to shorten that time frame?
Catherine, I don't know if you're able to speak to that or if you want to ask Mark to speak to that.
Thank you. I was actually just going to say you might need to phone a friend and ask Mark Townend to speak on that point because he is our current recruitment director, retiring at the end of this month. But I think he would have a better sense of that. If Mark, if you're still there, if you could speak up.
I'm here. The thing we're looking at in terms of verifications is, as most of you are aware, it's increasingly difficult to verify employment history. It used to be something where you just called a company and said, hey, can you tell me about the person who worked there? What did they do? What were the responsibilities? More and more so, companies no longer answer these questions, or they'll employ a third party who you have to pay to get that information. We previously pushed out the ability to agencies to make a best case scenario sort of situation call where they can decide, is it worth the amount of time it's going to take to verify that someone went to high school? I mean, imagine a case where someone needed a high school diploma and you're fairly sure they have it, but you just can't get them to produce it. Maybe they have a bachelor's degree, so you accept the higher degree as proof of the lower educational requirement. So we've basically given the agencies the ability to make the call and document that they have decided that verifying this specific piece wasn't germane to getting a person into the seat quickly, and that it's not necessarily productive. Of course, it's still in place for things like if you have a licensure requirement, a certification requirement, specific educational requirements for, say, an accountant. We have that still in place, but we did sort of open it up to interpretation, which is going to allow people to more quickly move people through the verification process.
All right, thank you very much.
Sure.
Delegate Chris, do you have a question?
I do, thank you. Just two questions. The first is this dashboard. Is it accessible to anyone or just mainly you got just DBM staff?
Hi, Delegate Grace. Thanks for that question. So it's timely that you ask. Just in recent weeks, we've had a number of inquiries, press inquiries and others about vacancy numbers. And preparing for this hearing, our chief of staff here at DBM had initiated efforts to figure out how to get it posted on our website going forward. So it should be available publicly on our website at some point soon. And then going forward, we'll plan to share that. We have been sharing it with DLS. I think with some staff transitions, maybe on our side and also on DLS's side, there's been some interruptions in data sharing, but trying to make sure that that continues consistently going forward as well.
And then my second question is, and I share the concerns that Senator Lamb has in regards to implications to the budget when we're hiring thousands of employees. And also too, when we're bringing contractual employees into our fold, because it's more than just salary, it's the entire compensation package that we're spending money on, and there's going to be an added cost to that as well. And also, I know it's difficult, not just for government but private sector to also hire, and this is, it started way before COVID. It's a huge challenge, but if we're hiring folks, if we're sort of lowering our hiring standards in regards to, qualifications, then you have that learning curve, and there's an expense associated with training. So I share those concerns too, just the added cost, because payroll is any organization's largest expense. And it seems like there really aren't any caps or any restraints on hiring and where we're hiring as far as strategy and in hiring the most needed positions, I guess. It just seems, I know I've seen, on social media, just notifications out there that the state is just hiring as quickly as we possibly can. But my question is moving forward, obviously we're in the customer service business. That's what we're here for. We're all here to serve the public, one way or another. And if we're hiring thousands of employees, is there any mechanisms or any measure in place that says, hey, our level of government service is better now than it was, 2 years ago or a year ago when we had 1,000, 2,000, 3,000 fewer employees?
Thanks for that question. That's a great question. And, one thing I would point to, I think the administration, the governor likes to say we are very much data driven and heart led, and we are putting in place not just the hiring dashboard that we shared with you today, but dashboards across the board with regard to the state plan around core priority state services. The governor has launched a performance cabinet, and we hired our first chief performance officer under the governor's office, Asma Mirza, who's doing pretty incredible work alongside the agencies to document exactly what you're suggesting. How are we seeing state services improve? How are we making progress with regard to our outcomes? And much of those discussions relate also to budget resources. This is an ongoing process. This is how you do strategic budgeting, is around resource allocation alongside outcomes and results. And we've been building that since the start of the administration. It's not DBM alone, so it's difficult for me by myself to speak to this. It's really an all of government approach to tracking the data alongside knowing how state resources and precious taxpayer dollars are being spent.
That's my final question, and best of luck to you guys and best wishes. I know you guys put a lot of hours in, and you're going to put even more in over the next 30 days. So
we're ready for
look
it.
forward to working with you guys.
Thanks, you too.
Great. Any further questions here? Does not look like that's the case. So I guess in communicating with Delegate with Chair Attar, I think we may want to flip the agenda for the remaining. If we can go to Medicare Part D and then end with the EEO piece, that would be helpful. So
Sure.
we want to bring the slides back up to slide 55.
It might be. I think that's right.
Yeah.
I think Dana was getting ready to suggest that too. So I appreciate that. This is a very, as you know, incredibly critical and urgent priority on DBM's plate. Delegate Grice just mentioned how hard we are at work on the budget. We are equally hard at work on ensuring, doing everything we can to ensure that our retirees successfully transition to Medicare Part D by December 31st. So I'm very pleased to have Christina Kaminsky, our head of Employee Benefits Division, who is working tirelessly to ensure that this happens. And she's going to update you on the work and what's ahead in these next few weeks. Thanks.
I'm sorry. Thank you, Secretary, and thank you to the committee for having me here. We're going to walk through some of the highlights here for the Medicare Part D transition. Quick cover of the agenda. We're going to talk about communications, outbound calls, a number of the activities that we've been conducting. Really, we've been conducting all year, but we have been on the move, really on the move since July. We'll talk about the enrollment update, some of the call center statistics with respect to our partner via benefits, and then ongoing, which the Secretary mentioned. Next slide, please. As everyone's aware, we did partner with Via Benefits. Via Benefits is part of the Willis Towers Watson organization. They are the top kind of Medicare marketplace in the country. They were really one of the first who became operational in 2004 once Medicare Part D was passed. One of the biggest focuses and the biggest selling points is their licensed benefit counselors, the people who can, and on a national basis, so that they could actually take calls and assist any of our retirees regardless of where they live. So They work one-on-one via telephone, and it is via telephone. We have a lot of questions on why it wasn't in person, and that is the Centers for Medicare and Medicaid Services does require that any enrollment is recorded, and it is part of their protection for what we want to, I guess, I'm hesitant to call them the elderly since I'm so close, but for the elderly, it is a protection on their behalf. And so we assigned more than 300 counselors to the state of Maryland account right up front. They assist the retiree through the comparison of all the available plans in their area. So it does vary by state. It sometimes can vary by county or jurisdiction. Within the state of Maryland, however, it was the same 10 plans available, regardless of where the retiree lived. Are we going to the next slide? You want me to move on? Okay. So the guidance was very specific based on the individual's needs, reviewing their medications, their budget, what pharmacies they prefer to use, and then the counselor was able to enroll the retiree on the spot if they'd like. They were able to put the plan in a cart if the retiree wanted to go back and use the online tool to complete the enrollment, or if they wanted to review it with a family member. So there were a lot of options, or they could call back at a later time and complete that enrollment. The other thing about using VIA benefits is that there's ongoing support all year round. So this isn't one time. This isn't a one-time offer for our retirees. This will be ongoing support throughout the year, and then for each and every Medicare open enrollment period. Next slide, please. Taking a look at, this is a very high level of the communication timeline, but we rolled out on September 9th. We made the announcement on our website. We mailed an announcement letter. I shouldn't even call it a letter. It was a guide. It was 8 pages long. One of my favorite pieces of feedback is on that announcement. And I have a letter here in my office where the retiree indicates that it was the most well done piece of communication she'd ever seen. It walked her sister, and her mother through the entire process of getting enrolled in a Medicare Part D efficiently and effectively. So we did that. That's where we started. The call center opened on the same day with VIA benefits, so they were able to take calls. The retirees were also available to sign up for webinars, and then our in-person educational sessions. So we rolled all of that out in advance as well. And then, of course, we had the websites ready. The VIA benefits website was available, where the retiree could actually go in and create their profile, kind of get ahead of schedule since the plans weren't available yet. That a lot of people did that. They enjoyed that resource. And then we had a recorded presentation available for them as well to give them an insight as to the program, the process, and how this was going to occur. So fast forward to the week of September 23rd, we mailed an introducing VIA benefits guide to each of the homes for the retirees, and we started the virtual meetings. There we had, we offered 10 meetings over the course of 1 week, 2 per day. We had capacity at about 5,000 or at 5,000, and we had over 4,700 attend a virtual meeting. So we had about 96% capacity at those 10 webinars. The following week, we started our in-person educational sessions. And you're likely aware that we had a session, we had at least one, actually we always had at least 2 or more session in each county throughout the state, and then of course the city of Baltimore as well. For a total of, we offered 98 sessions. We were able to accommodate more than 29,000 retirees. Unfortunately, we did not have the same participation at those sessions that we had hoped for. In fact, only about 20% participation in those locations. Some were filled. We had a lot of locations where people came out. I will tell you, on the Eastern Shore and in Western Maryland, a lot of participation. Not so much in the city and some of the surrounding areas. I will also add that I attended more than 60 of these sessions myself. And there isn't one session that we held that there weren't multiple people who came up and just said, this was so helpful. This made a difference. I understand. I'm going to go home and make that call. So it was really beneficial. I wish we'd had a little more participation. The other thing we did is get the get ready to enroll guide out. A lot of people brought those to the meeting, so those sessions, so they had them quickly. So that went out that same week. And then the special enrollment period started on October 1st. And that the retirees have a special enrollment period because benefits are terminating at the end of the year. So because they're losing group coverage, they had a full 3 months, October, November, December, to complete their election into an individual Part D plan. October 1st, the plans became available. That's when CMS releases the plans, and then they were able to begin enrollment. When you get to items number 5 and 6 here on the screen, this is really where we are now. We're still conducting open enrollment. We have some, when a retiree makes their election, Via Benefits does send out a confirmation letter, and then the insurance carrier sends the welcome kit because each person is selecting a carrier, their own carrier, and they get a welcome kit and their insurance card. So that's ongoing throughout October through December, through the end of this month. And then, of course, on January 1 of 2025, the coverage will go in effect. For those who are eligible for the HRA, the health reimbursement arrangement, they will also receive a reimbursement guide. Explains to them how to use their debit card or how to seek reimbursement should that be needed. The debit cards themselves have actually started to go out. They have been printed and are on their way. And so for people who enrolled early, they should have their debit card in hand prior to January 1. Next slide, please. This is a sample. Well, it's a snapshot of a lot of the communications. So the first is that cover letter, that announcement that we sent out in at September 9th. That was sent out under the state. So from the Employee Benefits Division directly, and then the introducing Via Benefits guide went out shortly thereafter, along with a reimbursement insert for those who were eligible for the HRA. So they understood that they were eligible, and they understood how much money would be allocated into their account as of January 1. We followed with the Get Ready to Enroll notification, which I touched on. And then recently we sent out the Last Chance postcard and email to those that we have an email address for, indicating that it is, time is running out and they need to make that decision. Certified letters went out to those who have not selected a plan as of just after Thanksgiving. So that was kind of the cutoff date that we used to determine who would receive this certified letter. And we did send that out to just over 11,000 households. So that has gone out. And then, of course, after the first of the year, or when the debit cards go out, there'll be a reimbursement guide for those who are eligible. Next slide, please. A couple other things I wanted to highlight. So we've talked about some of the informational outreach, and we just went through some of that. We have our dedicated website, which is being updated regularly. We have added a lot of FAQs, probably a little overwhelming, but there's a lot of information on our website. And of course, there's a lot of information on the Via Benefits website. We have taken the time where we can, and going forward, we'll continue to connect the two with links so that we are not updating two websites and we don't run the risk of giving out bad information or delayed information, so that we'll connect the two going forward. Some of the, we talked a little bit about the informational webinars and then the in-person educational sessions, how we held those. I wanted to highlight the average hold times in the call center. So I have it by month here, 8 minutes in October, 10 minutes in November, and then 20 minutes in December. Now that is only through December 8th. And as you likely know, the Medicare open enrollment closed on December 7th. So it was a little bit longer. People trying to get in at the last minute. That doesn't necessarily impact our members, most of our members, because they don't lose coverage until October 31st and they have more time. However, if you've watched TV, you know that the ads are just nonstop. So I'm sure it led to a lot of panic. I myself received several calls from panicked retirees, was able to calm them and assure them that they had more time and they would probably want to wait until this week to make a call where the phones are not quite as busy. So as of December 8th, we had 45,183 retirees and dependents enrolled in an individual Medicare Part D plan. I wanted to highlight some of the statistics, break that down a little bit further. Almost 45,000 of those retirees are eligible for one or both of the financial assistance programs, including the HRA. The total eligible for a financial assistance program is 57,000, just over 57,000. And then those who have access to VIA benefits, because everybody that retires from the state who is Medicare eligible has access to VIA benefits, whether they have access to one of the financial assistance programs or not. Again, ongoing and available to all of our retirees. Now, the numbers I've provided here exclude those that have indicated that they are not enrolling through VIA benefits. And how does that happen? That happens through the outreach that VIA benefits is doing to all of our retirees. So we still roughly estimated have about just over 15,000 that we'd like to see enroll by December 31st. Next slide, please. A few of the other statistics. Here you see where the VIA benefits is contacted contact our retirees, or attempted without a response, meaning no, they didn't actually talk to the person, and a conversation means if contact means two minutes or more. So we had over 4,500 that were contacted but did not enroll at the time. We've contacted over almost 15,000, but we haven't had a response from them. And then of course you see that same number at the end there, the 45,183 enrolled as of December 8th. One thing of note, we did expect that the offer of the financial assistance, the HRA program, would result in some additional enrollment. And it did. You can see the number there is 644 in addition to those that we knew of at the time we rolled out the program. In the next section, you'll see outbound calls made, and you can see that heavy focus at the beginning before October 1st, and then it kind of falls off a bit. And now that the Medicare open enrollment has closed, the focus has returned to reaching out to our retirees to get them enrolled. So as of this week, we'll see those numbers increase significantly. And then how many calls came in through the phone line is the next section there in gray. And there's a lot of fluctuation there. That doesn't mean they spoke to somebody on the care team. It does mean that a call came in, a call went out, or maybe they obtained their information just working through the IVF, and that was okay. And then the next section, how many individuals actually spoke to a representative. I know I talked already about the certified letters that went out, and then our calls will continue through the end of the year. Again, working to get people enrolled into a Medicare Part D plan. Next slide, please. I'm not going to read these. These are some of the testimonies that we have. Like I said, the feedback was fabulous at the informational sessions. We're getting testimonies all the time through VIA benefits, through this office here, and even a few people, as I mentioned, who've taken the time to write me a letter thanking us for what we're doing. And that can make my day, just so you know. Okay, on to the next slide, please.
Slide, please. Is someone still there? Thanks.
Okay. Every call, every retiree is asked if they'd like to complete a survey, satisfaction ratings. The scale's 1 to 5. This is at a high level, October, November, and then December through the 6th, which was Friday, and the scores are all above 4, whether it's an enrollment or service. So enrollment is going through the actual enrollment process, and then service is usually a general question, some guidance. Am I eligible for the HRA? Things along that nature. That's a general. And then you can see the aggregate score. So doing well. I will say the December, again, that number is going to be a little bit lower just because it's only the first week and it was the busiest time as all retirees were trying to get in, thinking the deadline was December 7th. Next slide, please. So what's coming up? I told you about the certified letters. We're going to continue outbound calls through the end of the month. The Medicare open enrollment has closed, and so VIA Benefits is focused on the remaining state of Maryland retirees. We're in constant contact, constant communication, and constant creating constant methods and mechanisms to improve our outreach and our communication, whether that retiree comes through the Employee Benefits Division or gets to VIA Benefits directly. As I said, the HRA debit cards are on their way out, which is great news. And then, of course, we have an ongoing campaign for people who either age in to Medicare, maybe they're already a retiree, but they were going to age in, and so they will need to transition to an individual Part D plan, or those who are retiring at a current month and are already eligible for Medicare, they also will need to make that decision. If we go to the next slide, you'll see some of those communications, especially for those who are aging in. So this is an ongoing campaign, and we start it 7 months before they become eligible for Medicare, and then we've got the 3-month and then a post enrollment communication as well. So this is ongoing, and then internally we are working on making sure that all of our benefit coordinators, our retirement coordinators know exactly what to provide retiree at the time of their retirement. A lot of retire words in there, but that's what we're working on here too. So I think that may be the last slide, and I'm certainly available to answer questions if anyone has any.
Yeah, that's the last slide. Any questions from the committee? Thank you for that overview. That's really helpful. So I think you outlined the steps that are remaining between now and I guess about 2 weeks when the deadline occurs on December 31st. Is there anything else differently that you plan to do besides that continued outreach? It sounds like there's telephonic efforts that are going out to try to reach people there. Some certified letters that may have gone out 2 days ago. Anything else? I mean, it sounds like there's still about 5,000 people that may have been touched but have not enrolled, and about 15,000 people that hard to keep track of.
Right. I think you've got it largely covered. So it's constant outbound calls. And we are the priority right now for VIA Benefits, given that general Medicare open enrollment has ended. So constant outbound calls. The certified letters are in the mail en route right now. And Rick Helkums, our chief of staff, who's not on the call, is working through strategy via media and other outlets to, do everything we can to get the word out. That's where, again, we would love assistance from the General Assembly through any venues that you have access to, as well as with our unions, our retiree focus group, who are members of various networks of retirees. We've been encouraging them to try and help us get the word out. When I saw the hearing scheduled today and that you wanted to add this topic, it pleased me because I'm hoping there may be some media folks watching who will also help us through their reporting to get this word out. we are open to all other ideas. And Christina, is there anything you want to add in terms of our efforts these next 20 days?
We will add an email campaign for those that have emails with us. I do want to be clear that most retirees do not have an email on record with us, but it has proved successful to use that as well.
Okay. All right, that's helpful. We appreciate the update. A lot of good work going in there. Obviously, still a little bit concerned about the numbers that we have out there. Obviously, understand that there's a full court press going on to try to reach out to those folks. And hopefully, fingers crossed, they'll get word in the next 2.5 weeks.
If I could make one additional comment, it was not uncommon to meet people who have alternatives. Either they were a federal retiree or a postal service retiree, or they could go on a spouse's plan. So I did meet a number of people that were in that position that were going in that direction.
Got it. So that could be some portion of the remaining that we haven't been able to hold up for him.
Yes.
It's also possible some of these folks may be deceased, right?
Yes. And we are tracking those as we get those numbers. Yes. Mm-hmm.
So is that 15,000 or so that you said that could not get contacted by telephone? Is that already eliminating those that we know are deceased, or is it?
It did. It eliminated those that we know to date are deceased. Yes.
Got it. Obviously, if we don't know they're deceased, they're still in that number.
Yes. Unfortunately, yes. Okay.
All right. Any other questions from members of the committee? If not, we can wrap up on the last topic. Thank you.
Thank you very much.
Minty. And wrap up with the EEO report.
Thanks, Christina. And just want to turn it over to Nicole Webb, our statewide EEO director, who has presented to this committee in the past and has prepared some updates for you around the EEO program. I didn't mean to say earlier that the EEO program is not equally critical to our work here at DBM. Of course it is. I know the urgency of the December 31st deadline on Part D has us very focused on that at the moment, but our EEO program continues to be a top priority for us as well.
Yeah, and didn't mean to implicate it that way either. I know we have some members that might have need to drop, so I think they want to hear about that as well. So we can turn to Ms. Webb. Go ahead. Thank you.
Right. Thank you, Secretary Grady. Thank you, Co-Chair Lamb, Co-Chair Tar, and members of the Joint Committee. And I'll try to be as quickly as possible with my talking points here. I'm going to provide an overview of the state's EEO program, data on our most recently published annual statewide EEO report, and finally, progress that we've made beginning January 2024 to date. So just starting with the OHCQ does administer and enforce the state's EEO program, monitors the program for statutory and regulatory compliance, reviews agency EEO decisions on appeals, conduct whistleblower investigations, and prepares the annual statewide EEO report. The state's EEO program is data-driven so that we may identify trends and monitor outcomes. To accomplish this goal, we continue to use the agency complaint tracking process with a uniform complaint form and a comprehensive database system. We do require agencies to annually set goals and develop plans to ensure that protected group members are represented and the personnel practices are not discriminatory. Next slide. Next, I'll cover the requirements of a principal unit's EEO program. Next slide. Each principal unit shall establish an EEO program to identify and eliminate discriminatory practices and policies. The head of each principal unit is required to appoint a fair practices officer who is an assistant secretary or an employee of the unit with stature similar to that of an assistant secretary. The head of each principal unit and the fair practices officer should regularly communicate the unit's EEO policy and program requirements to job applicants and employees. This can be accomplished by way of publishing EEO information on the unit's webpage, forms, new hire orientation documents, training, and providing coaching and guidance to managers, supervisors, and staff. Next slide. The Fair Practices Officer is responsible for implementing the unit's EEO program. They work in collaboration with the head of the unit and management staff to ensure policies and procedures are EEO compliant. They investigate complaints that involve an EEO protected basis and resolve as appropriate. The Fair Practices Officer serves as the direct supervisor for the EEO officer and coordinates their daily work activities. Next slide. The EEO officer is responsible for monitoring all personnel actions adopted by the unit to ensure that they are taken without regard to any non-merit factor. An EEO officer also conducts investigations into complaints, writes final written reports, designs, develops, and facilitates EEO training, attests that policies and procedures are consistent with statutory requirements. Next slide. ADA coordinators are a part of the EEO team as well and work with management and staff, as well as job applicants to facilitate the interactive process when there is an accommodation request because of an employer job applicant having a disability and limitations that require modifications to the recruitment process or work environment. The ADA coordinator provides training to agency staff on applicable disability laws, policies, and procedures. They also ensure that all workspaces are accessible and compliance requirements are met. Next slide. Employees and job applicants that wish to file EEO complaints must do so in writing with the head of their principal unit or EEO officer within 1 year after first knowing of or reasonably knowing of an alleged violation. Within 60 days, the EEO officer is required to conduct a thorough investigation and recommend a proposed decision to the head of the principal unit. The head of the principal unit issues a written decision to the complainant and may grant any appropriate relief. Next slide. Employees have the right to file an EEO complaint under Section 5-203 of SPP or file a grievance in accordance with the state grievance procedures in Title 12 of SPP. In addition to filing an EEO complaint under SPP, employees may elect to file a complaint with an external regulatory agency. Next slide. The OSEOC enforces the EEO appeals process. Therefore, within 10 days after receiving a decision from their principal unit's EEO office, an employee may elect to file an appeal in writing to the Secretary of Budget and Management or myself, the statewide EEO coordinator. The appeal and decision are reviewed and an investigation is done within 30 days. Next, a written decision is issued to the complainant and the respondent. If there are no violations, the case is dismissed. If a violation occurs, the secretary or designee shall take appropriate remedial action. The decision of the secretary or designee is final. Next slide. So next, I'm going to share FY24 data from the Office of the Statewide EEO Coordinator. Next slide. In FY24, there were a total of 593 EEO complaints. The most common bases were disability, race, and retaliation. 446 of the 593 complaints were filed internally with the agency's designated EEO office. Of the 446 internal complaints, 25 were appealed to the Office of the Statewide EEO Coordinator. While there is clearly an increase in EEO complaints from FY23 to FY24, 75% of the EEO complaints were filed internally in FY24, opposed to 74% in FY23. This is an indication of employees trusting the internal EEO complaint process to address their concerns. In addition, there was an increase in appeals filed from FY23, which was 20, compared to FY24, which was a total of 25. Next slide. The OSEOC is also responsible for enforcing the Maryland whistleblower law in the executive branch of state government. The purpose of this law is to further good government and ensure that no supervisor, appointing authority, or the head of a principal unit does not take or refuse to take any personnel action as a reprisal against an employee who discloses information that the employee reasonably believes evidences an abuse of authority, gross mismanagement, gross waste of money, a substantial and specific danger to public health or safety, or a violation of law. We did see a decrease here in FY24 when compared to FY23. In FY24, there were a total of 13 complaints filed. 10 were no probable cause and 3 were withdrawn. It's important to note that in the event that an employee wishes to withdraw a whistleblower complaint, we do have a best practice of having them put that request in writing, so that way we will have it for our records. Next slide. In FY24, there was also a reduction in sexual harassment complaints when compared to FY23. There was also a reduction in probable cause findings for FY24 opposed to FY23. Next slide. Next, I'll provide you with statistical and demographic data on the state's workforce for FY23. The data going forward in the presentation does not include higher education institutions, and it's important to note that we are currently working to complete the FY24 annual statewide EEO report. Next slide. In FY23, the state's workforce consisted of 56% of employees that identified as female and 44% of employees that identified as male. The state's workforce, next slide, I'm sorry. The state's workforce is diverse, with 44.8% white, 44.4% African American, 2.8% Asian, 2% Hispanic or Latino, 5.8% multiracial, and less than 1% that identified as Native Hawaiian and Pacific Islander, and American Indian Alaska Native. Next slide. Next is a comparison of state employees to the civilian labor workforce. White males and females, as well as minority males, represented a higher proportion of the civilian labor force than the state government's workforce, while minority females represented a higher proportion of the state government's workforce than the civilian labor workforce. Next slide. Next, this chart reflects the total percentage of new hires. Total percentage of women as new hires was 56% and 43%. There has been a trend from FY 2018 to FY23 in which women were hired at a higher percentage than men. Next slide. Next, this chart reflects the total percentage of minorities as new hires. In FY23, 52% of new hires identified as a minority. There has been a trend from FY18 to FY23 in which minorities were hired at a rate of 50% or higher. Next slide. Next, this chart reflects the average salaries by gender and race. The average state salary was $73,699. The average salary for men was $78,313, and women $70,663, a difference of $7,650. There was an average pay difference between white and African American employees of $13,310, which can be attributed to the jobs that they hold. White employees held 60% of the officials and administrative positions, opposed to African Americans with 26%. White employees held 46% of the professional level positions, opposed to African Americans with 41%. Next slide. Next, this chart reflects gender and race representation by job category. Women had more representation than men in the officials, administrators, and professional positions, which have higher salaries, but the average salary is most likely driven down by the significant proportion of women representing administrative support positions. African American average salaries are similarly driven down by heavy representation in service maintenance and the administrative support categories. Next slide. Next are percentage of promotions for women. In FY23, women accounted for 60% of the promotions. There has been a trend from FY 2018 to FY 2023 in which women receive promotions at a rate of 49% or more. Next slide. Next are the percentage of promotions for minorities. In FY23, minorities accounted for 50% of promotions, African Americans at 43%, and other minorities 7%. Next slide. Next are the total suspensions and terminations captured for FY23. Starting with suspensions. African American employees received suspensions at a higher rate when compared to white employees. However, they also occupy more positions subject to progressive discipline, which could account for some of the skew. Next, terminations. African American employees were terminated at a rate higher than white employees. The OSEOC has increased auditing practices to ensure that EEO officers are monitoring their policies and procedures to ensure that they are EEO compliant and not creating I'm sorry, let me read that again. My apologies. The OSEOC has increased auditing practices to ensure that EEO officers are monitoring their policies and procedures to ensure that they are EEO compliant and not creating disparate impacts. In addition, we ensure that EEO officers are monitoring all personnel transactions to confirm they are warranted in compliance with applicable policies and procedures. Next slide. So the next few slides, I'm just going to kind of summarize it all together so you can go to the next slide after this. Thank you. The OSEOC has continued to audit agencies' EEO programs to ensure compliance with federal and state EEO laws, policies, and best practices. We also publish the EEO Connection newsletter quarterly to provide news and EEO program updates statewide. We have continued our EEO professional statewide group meeting, which is hosted twice a year. This is where we share the coordinator's vision and goals for the program. Finally, we have continued to offer quarterly professional development training to EEO professionals, as well as other state employees interested in participating in our sessions. So with that being said, that concludes my presentation.
Thank you for the presentation. Are there any questions from any of the members?
I did have one question to follow up on what you were saying. You referenced the fact that for folks that are not pursuing any EEO complaints and withdrawing them, that needs to be done in writing. We have had folks reach out to us because they feel like these are state employees that feel like they've had and brought to the attention of their EEO departmental officer a concern. And then they thought that was being followed up upon, and later find out that because they had not filed anything written, that complaint was never actually documented. It never actually basically occurred. And so, I guess to follow up on the process that you have for withdrawing complaints, can you incorporate into your process with the EEO officers across the different departments that if an individual calls, voicing some concern, but not following up with a written complaint, when they call, can you incorporate something like a Miranda rights kind of disclosure to them that it's clear in that conversation that you should know that unless you follow a written complaint, this is not going to move forward as a real complaint, that our conversation is not a real initiation of a complaint-driven process, that you have to file a written complaint with us. Because I think there's a misunderstanding among some employees who reach out to their EEO office that, oh, I thought I had a conversation that started the complaint process. At least in conversations of people that have reached out to our office, it seems like there's a misunderstanding there.
Yes. So what I can say is, in terms of training, we do have a great partnership with the Maryland Commission on Civil Rights, and there is a training that their general counsel provides to all newly appointed fair practices and EEO officers. It's entitled Investigative Techniques and Legal Theories Training. It's a 2-day in-person training that all fair practices and EEO officers will take part in. And a part of that curriculum is to cover how to handle calls, like inquiries about how to file an EEO complaint. And it is a best practice to, of course, provide a verbal overview, but to also follow up with that individual in writing with what you discuss and links to the forms and things of that nature. And if a person does not respond within, let's say, a 48 to 72 hour time frame, to follow up with that person to say, hey, just wanted to follow up. What more, how would you like to proceed with this process? Because the reality is, with some certain information that is shared, even if they choose not to move forward and file a written complaint, that EEO officer may still have an obligation to act on what was shared with them. So that is done by way of that training. And we do also have what's called the statewide EEO overview training that is facilitated by myself and my team that is offered to the statewide EEO community as well. And I'll just say finally, when I am made aware of specific agencies, such as the one you're referencing, because I'm aware of that one, who had 2 individuals who reached out saying that nothing was done, I did follow up directly with the Fair Practices Officer boss to discuss that, and it was addressed with them because that person was newly hired into the role.
Okay. If you don't mind, if you could just follow up with our office, and we don't need to go into the finer details of this, but I think the process you outlined would be helpful for us to understand a little bit more depth to see if there are other touch points along that process that we can make it explicitly clear for anyone contacting our fair practices officers in those departments that maybe there's in that discussion that we have with you an ability to look at some other places that we can make sure that this is explicitly clear to those employees, so there's no misunderstanding whatsoever.
Absolutely.
So we'll follow up. Thank you.
Thank you.
Any other questions from the committee? No? Okay. All right. Well, thank you, Secretary Grady. Thank you, Ms. Webb, and to your team. We appreciate the update here.
Sure. Thank you all.
Thank you.
Okay. Thank you. And to close out our agenda, we have Ms. Denise Gilmore from AFSCME. And you can go ahead.
Yeah, good afternoon, chairs Tar and Lamb and members of the committee. As stated, my name is Denise Gilmore. I'm the legislative director for AFSCME. I really appreciate the opportunity to share the perspectives of our members who are on the front lines in agencies like the Department of Health, whom you heard from today every day. And I must say, given that it is about 1:30, I also really, we appreciate the time you've dedicated today to continue to dedicate to ensure that our state workforce is treated fairly and meeting the needs of Marylanders. I think this is going to become all the more important, unfortunately, as we look at any federal changes that might be on the horizon. I promise I'll be quick with my remarks. I'd like to talk about the Perkins presentation first, and then briefly touch on the presentation that you from DBM that you just heard about. At Perkins, we represent nursing and security department staff, social workers, psychologists, maintenance workers, rehab, and administrative staff. I cannot underscore enough what tough jobs these can be at times. Personally, I've had the incredible privilege of working with our local at Perkins directly or indirectly for the last 15 years. I have personally seen the dedication that our members at Perkins have in seeing these individuals restored back to places where they can safely return back to their communities. And it's truly inspiring to be able to see them, obviously, through the COVID-19 pandemic. I believe they truly are heroes. It's especially impressive. Their dedication, I think, is especially impressive given how short of resources they are, and certainly all the chaos that has happened in recent years that's been talked about today and certainly well reported on. As of November, our bargaining units, and again, we represent the vast majority of staff at the hospital, our vacancy rate in our bargaining units there is about 30%. The majority of these 132 open positions are in the security and nursing departments. This is incredibly dangerous. It harms staff's ability to provide safe and effective care to these vulnerable patients. We agree that it's not just direct care and security that is currently under-resourced. All departments are suffering from a lack of resources. Our social workers report that they are covering multiple units, impacting their ability then to do the critical discharge planning work that was talked about earlier, to keep patient flow in and out of the facility moving. The list of patients waiting to get into these facilities is higher than I've seen it, certainly. And unfortunately, we have less bed capacity today than when I started. Just for perspective, We do caution against moving away from the security ratios that the General Assembly wisely placed into law back in 2020. It was in fact clinicians that were among the first to testify with us when we asked for more security. I think all healthcare workers want to work in a safe, therapeutic environment, and our security personnel play a really important role in that. If I can just very quickly read one comment that I received from a member at Perkins 2 days ago, actually, it reads, I'm always a team player. However, you are not going to continue to put me in danger. 3 staff and no security officer on the unit with 28 patients and a 1-to-1. This is horrible and I'm over it. If we think about why staff are leaving, it is oftentimes because they feel like they don't have the security support and safety or support that they need to stay safe at their jobs. So they do, we do think they're going to play a critical role in recruiting even other classifications in the facility. For several years now, our members at Perkins have been speaking up about the toxic workplace culture there that often was promoted by facility management. They've been pleading for more resources and better training. Since CEO Moran left and the outside consultants have begun their review, there does seem to be progress in terms of collaborating with our union, of course, the elected representatives of the employees. We do want to commend the secretary for that. However, this toxic culture unfortunately still exists, and particularly in the nursing department, the largest department in the hospital. So unfortunately, these issues are still casting a large shadow over this facility. Moving forward, staff really want to see leadership changes in that department particularly, and more accountability at the top, and a real commitment to properly resource the facility and to work with us to achieve better training and more frequent training. We are eager to welcome and work with the new CEO. I think stability and leadership will be critical as we work to make improvements in this facility. I also want to commend the secretary for taking a larger oversight role over the facilities. We have recommended to every new health secretary, since I've been here at least, that secretary level oversight of these facilities is critical to functioning of these facilities. And I'm certainly very relieved to hear that will be occurring moving forward. In some ways, the issues at Perkins are unique, but in other ways, they are emblematic of what is happening across, quite frankly, many of our agencies, particularly in other congregate living facilities like our prisons and juvenile detention centers. Facilities are outdated. There aren't enough resources to keep staff safe, or those in Maryland's custody are care safe and properly cared for. The previous administration left a backlog of over $1 billion in deferred maintenance and historic staffing shortages, as I know many of you are aware of. Since 2010, inflation has outpaced state employee salaries. This hits particularly hard on our veteran staff that we so desperately want to keep. 75% of new hires in the last 2 years were hired at a step 5 or above, which leads to greater wage compression for the employees who have stayed over the years and missed increases when they weren't budgeted. I commend DBM for engaging the unions in a pay equity process over the summer, after their own study found that state salaries in the standard and correctional salary plans were uncompetitive in many areas. And it is, encouraging to hear the secretary reaffirm the state's commitment to prioritize rebuilding the state, but continued work to make salaries more competitive must be a part of this plan if we're going to achieve these goals. We do fear that things will only get worse without more urgent action here. State employees currently are still getting assaulted way too often, almost 9 times a day on average, in places like corrections, where we've seen a member recently have their finger bitten off. We've had another member so violently beaten that they had to be rushed to the hospital during a shift. We lost a member tragically this year in a line of duty death when parole and probation agent Davis Martinez was murdered while conducting a client visit back in May. It's been a really tough year. We've made great progress converting contractual positions, But converting contractual positions doesn't add staff, unfortunately. It gives these employees the rights and benefits they deserve, and we appreciate the administration working with us on this. But overtime usage is still too high. Too many posts are understaffed or unstaffed altogether. And in too many places, we still need more positions to be appropriately staffed. We see tremendous urgency here and hope to work with the administration and the legislator to find solutions now. Just my final note of feedback pertains to our state retirees. I really appreciated the update that we just got on the efforts being made to enroll retirees. Our retiree chapter has been tracking stories of members attempting to sign up. It is a very complicated process for folks. We do ask that the legislator continue their oversight of this transition into the next year. DBM released metrics towards the end of last session, estimating that I think roughly 3 of 5 retirees will see costs stay the same or go down under the transition away from the state prescription plan. I think, state retirees will certainly have a better sense of this once they start hitting pharmacy counters in January. And it would be good to know if we meet those estimates. After years of dedicated service to the state of Maryland, our members deserve to retire with dignity. That's all I'll say today. Thank you. I'm certainly happy to take questions, or because of the time, if you'd like to follow up with me or any of our members in these agencies and departments you discussed today, please don't hesitate to reach out. I assure you that our members are always incredibly candid and happy to always partner and talk about how we provide better services to Marylanders and improve working conditions. So thank you again for the opportunity to provide comment today and for providing critical oversight over these issues.
All right. Thank you. And any questions from the committee for Ms. Gilmore? All right, we appreciate the insight and also the perspective from the folks that asked me. Thank you. I think we've reached the end of our agenda, and we can go ahead and wrap here. Hand it over to Chair Attar to see if you have any closing remarks. I know the hour is late, so just hand it over, and if not, we can go ahead and wrap up.
Yes, thank you all for joining. It was nice seeing everyone again, and take care.
All right, thank you. We're adjourned.